Evening faculties and delegates, thank you for joining Shield Connect. I am Nishan Chawda, Regional Medical Advisor from Shield Healthcare. It's my privilege to welcome you for this wonderful series, Trending Us series, which is organized by AGOG, that is the Academia of Global Obstetrics and Gynecology, on Shield Connect platform. So in this task series, we will be covering the topic from A to Z topics, and today the episode L will cover the topic Leap on Leiomyoma Laparoscopically. So before we start with the series, let me show the short introductory video for AGOG. And with that, let me start the episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now I am happy to introduce the coordinators for today's episode, Dr. Aditi Tandon and Dr. Amuk Chimote. Dr. Aditi Tandon is obstetrician, gynecologist, endoscopic surgeon at Sudha Tandon Fertility, IVF, Endoscopy and Maternity Center at Chembur, Mumbai. And let me also introduce Dr. Amuk Chimote, sir. He is a medical director at a Vasundhara Fertility Center at Nagpur, Maharashtra. So I am glad to hand over this session to Dr. Aditi Tandon. Thank you.
Thank you, Nishant. Welcome all faculties and delegates to this very interesting task series webinar on everything related to leiomyomas. It is my privilege to introduce and welcome our convener for the program, Dr. Komal Chavan. She needs absolutely no introduction, but for the sake of introducing, she is medical director at Chavan Maternity and Chavan Maternity and Nursing Home. She is a senior consultant and DNB teacher at VN Desai Hospital. She is chairperson of the FOXI Medical Disorders in Pregnancy Committee, past chairperson, zonal coordinator for FOXI, chairperson for a MOGS Family Welfare and MTP Committee. She is managing council member of MOGS, joint secretary ISOPAR Mumbai chapter, premises secretary AFG, and she is national expert for FOXI UNICEF Lakshya project and national trainer for FOXI Dhira and RAC project. Welcome, madam.
Yeah, thank you so much. Yeah, thank you so much, Aditi. And gives me an immense pleasure to welcome you all today for this episode L of A to Z series. And we are doing the series from A to Z, and today's episode L. And L is nothing but a leap on leiomyoma laparoscopically. And we all are here with a common aim to have these challenges which we encounter when we do complex surgeries which are involving leiomyomas. And we have all the stalwarts today who have joined, and I'm so honored with the presence of Dr. Niranjan Chavan also, who is a co-convener. And we have our chief guest, Dr. Prakash Trivedi, guest of honor, Dr. Bhaskar Pal, eminent speakers, Dr. Nikita Trehan, Dr. Sunita Tandulwalkar, Dr. Amay Padwawar, our panelists, Dr. Sejal Nayak, Dr. Kalyan Barmade, PG Paul sir, and so many friends who are the chairpersons, Dr. Sandesh Kade, Sushila Sahani, Ashish Kade, Vidya Bhatt, then Devin Jogal, Damodar Rao, and the cream of the panelists which I have today so well. I think Aditi has coordinated this very well in getting all of them together. Dr. Sujal Munshi, Dr. Yashodan Deka, Subhash Malia, Dhaval Pelvi, Surakshit, Dr. Tarun Joseph, Amit Kazane, Shrikant Ohri, and Gaurav Desai. I think a real great team of people have joined today. We are like-minded people. We all, on a common subject, we are going to have a good discussion. And I take pleasure to invite our chief guest, Dr. Prakash Trivedi, sir. And when we talk about laparoscopy, the name which comes into our mind is none other than Dr. Prakash Trivedi. He is like a pioneer in laparoscopy, and we all look up to him when we see all these complex cases in myomectomy. He has become the first person to do so many things in the laparoscopy, the nuances in laparoscopy. So he is consultant gynecologist, endoscopist, ART consultant, sonologist, and a urologist. Also pioneer in hysteroscopic, laparoscopic suturing, 3D light laparoscopy, in-bag morcellation. Everything you talk about, it is Dr. Prakash Trivedi, sir, director of Trivedi's Total Healthcare and Akar IVF Center, past president of ISAR, FOXY, as well as IAG, FIGO endoscopic chair and AOFOG endoscopic committee member. And sir is also organizing the very much awaited AAGL conference, which is there in Mumbai. So over to you, sir. I think if I introduce you, it will take the entire day to introduce because few words are not enough. But I think the name is enough, Dr. Prakash Trivedi from Mumbai, India.
I was about to tell, don't introduce only. And such a pleasure and privilege to join program, especially Komal is working hard and organizing this program. But I think so seeing the list of people, I feel the entire IAG is there. I think all big endoscopies, all important endoscopies. So I think the signs of leadership is seen from there only. You have some of the best speakers, and obviously fibroid is a subject. Sometimes, people say you are born for something. So I always feel that fibroid was born for me. Fibroid was born for me, so I keep working continuously, and I still keep working continuously. We wish a lot of success to everybody participating. And Komal and Niranjan and all of you are doing a great job. All the remaining people are my colleagues, in the field. So I think so. We will be enjoying the program. Thanks, Niranjan. Thanks, Komal. I will be hearing most of your program.
Thank you so much. Thank you so much. And one more thing I want to announce, we are having the AAGL India 2023. We are having this after 8 years, and Dr. Prakash Trivedi is leading at the forefront of AAGL. Thank you, sir, for getting this back in India, along with Dr. Puntamrekar, sir, and other stalwarts, where the whole of Southeast Asia, the whole world is going to land in Mumbai. So we are all geared up for that program also, sir, and we look forward with everyone's participation so that, we all learn. There are going to be many, many cases, many, many operations, and so many knowledge sharing platform, events, roundtable conference, roundtable meetings. And we are going to have debates, lectures, live sessions, 3D, whatnot. All the instruments from all over the world are going to come. And sir, we are very grateful to you to get this opportunity to Mumbai. Thank you so much, sir, for being there today as a chief guest.
Pleasure and thanks.
Thank you. Thank you so much, Dr. Trivedi, sir. And now I welcome our guest of honor, Dr. Bhaskar Pal. Dr. Bhaskar Pal, as we know, he's a senior consultant gynecologist from Apollo Multispeciality Hospital, Kolkata. He has organized the most loved AICOG, that is AICOG Kolkata, and as an organizing chair. And he's immediate past president of IAGE, chair of AICC RCOG, and also the immediate past president of Bengal Obstetrics and Gynec Society. He is also an excellent author of almost 35 papers and chapters in book, a great academician and a leader. So over to you, Dr. Bhaskar Pal. Please address the audience.
Sir, we cannot hear you, sir.
Bhaskar, please unmute.
Sir, we cannot hear you, sir.
Maybe the microphone is disabled.
We could actually hear you earlier. Yes.
No, sir, still not audible.
I think Zoom knows that Bhaskar talks too much. So probably he has muted him. But anyway,
But when he
I
joined, we
I
could
think
hear.
he's,
Yeah.
no, yeah, I think he can hear us, but there is some technical issue. Host, yeah, Bhaskar, can you please hear us? I think he should rejoin again.
Yeah, he will rejoin in a means time.
Bhaskar, I think he can rejoin. Saita, host, can you just coordinate with Dr. Bhaskar and we can go ahead once he joins.
Yeah, he's joined again. Yeah.
Yeah.
Yeah, I think we have Dr. Bhaskar Pal joined again and
It's still not audible.
still not audible. I think with the headphones, we are not audible.
No, sir, still not audible.
Welcome, Dr. Sandesh, Dr. Nikita, Dr. Deven. We can see you all. We just started the program. Dr. Prakash Trivedi sir has just given his chief guest address. Dr. Bhaskar is just connecting. We apologize for the technical glitch which is there right now.
Yeah.
Hello.
Yes.
Am I audible now?
Yes. Yes.
Okay. Can you hear me?
Welcome.
Yes, we can hear you. We can see you now.
Yeah. Okay. Thank you very much, Komal, for the kind invitation. And the who's who of endoscopy is there. We can see some very senior speakers, and we can see all the young Turks of endoscopy in India today to deliberate on a topic which we come across every day. And I think that the huge majority of fibroids, the default mode of management is endoscopy. So I think it is a very, very useful discussion today. As Niranjan said, I think for the next few weeks, we cannot have
And there seems to be a network issue, I guess.
Hello.
Yes. Hello.
Yeah,
Yes,
for the
Bhaskar.
next few weeks in India, for the next 4 weeks, we cannot have any endoscopy meeting where we do not talk of the AAGL Global Congress. AAGL Global Congress happens by turn in different countries. Happened in India in 2015, and I think India is the first country which was again awarded it in a matter of 5 years in 2020. And we had to, because of COVID, it was rescheduled and it's going to happen again. It's again in a once in a century event. So I look forward to everybody joining there, showcasing your work. And we still have, today is still last day to apply for the award for the young endoscopists. Kamal is a dear friend and Niranjan is a very old friend. And Kamal has been an excellent chairperson of the Medical Disorders Committee of FOXI, and she is very, very active in other organizations, including the Mumbai Obstetric and Gynae Society. As Kamal embarks on to take on more important responsibilities in the form of Vice President FOXI, I wish her all the best for her upcoming elections. I wish this program all the best, and I'm sure that all of us will be enriched by the content today. Thank you very much for inviting me.
Thank you so much,
Thank
Dr.
you,
Bhaskar Pal, sir, and Dr. Prakash Trivedi, sir, for your kind wishes. And I'm really honored by your presence today. And we have all our esteemed faculties waiting. So over to you, Aditi and Amo. Aditi, unmute.
Thank you, madam. We will now begin with the first lecture of the session. It is on challenging leiomyomas by Dr. Nikita Trehan. I would like to invite our esteemed chairpersons for the session, Dr. Sandesh Kare, He is the team member for the first uterine transplant of India and the first laparoscopic uterine transplant of the world. We all know he operates at Abu Dhabi at Bahrain International Hospital. He is also a visiting endoscopic surgeon to the busiest IVF center, FMC, in UAE. He is director and consultant at Solapur, and he also visits countries like Kenya, Bangladesh, Nigeria, and he is also trained many budding endoscopic surgeons. Welcome, sir.
Yeah, and one more point, he has just conquered the Everest. So I think that is something we have seen in updates.
That's phenomenal. Our next chairperson is Dr. Sushila Saini. She is founder director of Jaipur Durbin Hospital, director JDH Healthcare Private Limited. She is the chief editor and publisher of the book called Step by Step Approach of Learning the Art of Endoscopy, founder president of AGESR, founder secretary of IAG Rajasthan chapter, and managing committee member of IAGE. Welcome, madam. Requesting our chairpersons to introduce our first speaker, Dr. Nikita Trehan.
Thank you, Aditi, for a kind introduction and inviting here. I would like to thank Dr. Kaumal Chavan and Chavan sir. And I think Dr. Sandesh, will you like to introduce Dr. Nikita? Because Dr. Nikita is a very good friend of ours, a very good endoscopist, and is regularly visiting our center also for conferences. And she's working at Sunrise Hospital. And Dr. Sandesh, something you want to add?
Yeah, it's an honor to introduce Nikita.
Yes.
And and the very apt topic given to her, the challenging myomas, because somehow she has that magnetism to attract all difficult cases. She has all these difficult surgeries in pelvic floor and and I won't dilute her topic by telling you that she has myomas at extra pelvic sites very far off. Just to give you a hint, maybe I'm sure she might show you the cases of something in liver and all these things. So I welcome Dr. Nikita to deliver her speech on challenging myomas.
So thank you very much for that wonderful introduction. Sandesh and me did our fellowship together with Dr. Hafiz. 16 years back, Sandesh, we become old now. So without much ado, I'd like to thank Dr. Komal Chauhan for letting me be here today, and also wish you a very prosperous year for your vice presidency. And we've already accepted you as a vice president, so goes without saying, there's no debate there. So I'll just start with my screen share. Just bear with me for a second. Is the presentation visible now?
Yes, ma'am.
Okay. So basically, I'm going to stick to the basics. I've been told that I should stick to the basics and not go for very, very difficult things. Sorry, just a second. So first of all, one of the biggest challenges we face nowadays is that multiple myomas, very large myomas, and how do we take out these myomas by laparoscopy? So we have got one of the largest records, 6.5 kg taken out by laparoscopy. When we are operating on a very large fibroid, we have certain concerns. How do we need an operating distance. If you go too close to something, you can't see it. So when you have very large fibroids, then your operating distance is something which gets compromised. So you have to put the trocar much higher up, and we put it at the Lee Wang's point. So between the symphysis pubis, and the xiphisternum, depending on the size of the uterus, whether it's hysterectomy, myomectomy, whatever, we have to give ourselves an operating distance and then put the primary trocar. So sometimes we're putting it at the xiphisternum. It's a 36-week size uterus with multiple myomas. I'm at the xiphisternum, and still you can see it's broad also, it's thin. The intra-abdominal pressure is quite high, but despite that, you can see that there is no space. So when it comes to very large fibroids, our first challenge is how do we look at it? How do we operate? And if at all bleeding starts in these areas, how do we go about it? So when you have very large fibroids, the first challenge you face is the operating distance. And for that, go much higher up, put your trocars. Don't be shy about putting an additional trocar for additional manipulation. And then you can start with your, after you've seen it, you can start and use everything. For your manipulation, you may have to use, like here, you can see I've used harmonic, I've used bipolar. So what are the standard steps when we do a myomectomy? When we're doing a myomectomy, we have other steps which we need to control is the hemostasis. The second challenge which we face is the hemostasis. So in hemostasis, you have to do many times a bilateral uterine artery ligation. Now this is being shown in every workshop. I'm sure everybody knows how to do it. So when it is needed, you can do a bilateral uterine artery ligation after injecting vasopressin at one point. And here you can see that when you inject the uterine artery, a lot of people have myths that she cannot have pregnancy later, or there will be a lot of issues later. Sandesh will tell you from his uterine transplant experience that there's 7 uterine arteries, and clipping the one which is supplying the fibroid is not going to really compromise the vascularity, but it will prevent the recurrence of fibroids. And in multiple fibroids, it's a very good procedure which we use. Enough studies to show fertility after lual is not compromised, and there is no increased incidence of Asherman's also. So this is a procedure which we would say in multiple fibroids or very large fibroids is an extremely helpful procedure. Now, there is another method, which is the temporary uterine clipping, which is recommended by Sanket Pisat. He does the shoelace knot. But when we see that if we, for half an hour, these small capillaries, which the uterus, the end arteries, which are supplied by the uterine, once they are stopped, microemboli form. And then even if you take out that clip, it's not much of a benefit for that area. So here, first rule when you're doing a myomectomy is that your hemostasis should be comfortable so that you're not panicking, your team is not panicking. When you're doing a myoma removal, enucleation, give a good large incision so that you can take it out. Otherwise, if from a small incision, you'll keep pulling out and then cause more harm. Give a large incision, go into the depth, see where you are, and then take out this fibroid completely. Traction and counter traction. You can use scissors as an alternative source for taking that out. And while suturing, we use V-lock sutures. We can use any barb suture, but V-lock has made your life simple. Now, this is a standard procedure. One of the tricks we use is that you're making a vertical, posterior vertical is a little difficult to suture. So we convert it by twisting it around and making it horizontal so that it becomes easier for you to suture. So as we all know that there are lots of methods to control bleeding while we are doing a myomectomy. You can use prostaglandin, you can use vasopressin. We use oxytocin a lot, 40 units of oxytocin. We should know that oxytocin works on the non-pregnant uterus also. So when we use oxytocin, we use 40 units in 500 ml saline, keep it running, and that really helps in controlling and giving good hemostasis. You can use misoprostol as well. Now, when you have a broad ligament fibroid, so suppose you have cervical fibroid, broad ligament fibroids, these are areas which need a little more attention. So when you have a broad ligament fibroid, they could be anterior, lateral, posterior, or deep broad ligament fibroids, any of these 5 types. With broad ligament fibroids, your basic funda should be that you should take out the fibroid completely out, and then you will be able to see one feeding vessel at the base. So herein what you can see is this is the broad ligament fibroid. You should know where your ureter is at all times. So between the uterosacral and the broad ligament over here, you are finding that this is in the Okabayashi space, you have this broad ligament fibroid. You know that the ureter will be lateral here because this is a false broad ligament fibroid. It's not a true broad ligament fibroid. It's not coming from the broad ligament and it's arising from the uterus, which is 99% of these broad ligament fibroids. So essentially what you're doing here, what I'm doing here is going to completely pull out the fibroid from the broad ligament. And at the base, you will see one feeder vessel. So completely take it out, pull it out completely onto the opposite side. And then here you can see at the base, you will find one vessel. And that is the only vessel which used to get avulsed when people used to carelessly pull out. And then that is why they used to say that broad ligament fibroids bleed a lot. Nowadays, when we are doing broad ligament fibroids don't bleed because we know very well that we have to keep in mind where the feeding vessel is, where it's coming from the uterus. Once you bear this in mind, then there will be no bleeding whatsoever because this is you're clipping or you're coagulating the feeder vessel. So this is how you take out a broad ligament fibroid. Now you may get a challenge of a necrosed fibroid. So many times now this is when we have something called press score. So when you have fibroids where you're wondering, oh, could it be a sarcoma, whether it's degenerated, especially in these girls who are having ulipristal and coming. We get a lot of them in North India, despite being completely discouraging towards, taking these medications for long. You'll find a lot of degeneration, like this particular case, what I'm doing. This, you can see that there are a lot of degeneration which is there in this fibroid. I'm cutting it with the scissors. There's no correct plane because all this ulipristal and some Ayurvedic medicines cause this degeneration. In order to handle such fibroids, you have to be gentle, know the plane, and be sure where your cavity is. And take that fibroid out. So you can see my cavity somewhere here. And then I'm gently cutting it from the uterus and taking this fibroid out. We did a true cut biopsy in this case. So whenever you have a doubt on how to handle a degenerated fibroid, because there is something called press score. So I'll just show you what the press score is. This is the press score. So you have the preoperative scoring where you can operate or not operate depending on the risk for sarcoma. So you have an LDH level, which is less if it is more than 279. If you have, the age of the patient more than 49, or the cytological findings. If the cytological findings are on a higher risk, then you may even go and do an endometrial biopsy. And depending on the revised press score, you will go ahead and do it. MRI was previously included in the press score, but later on the univariate analysis, they found that MRI is not so predictive of sarcoma. So now this is the revised press score, what is there. So like I said, one of these things is the revised press score. Sorry. Another such case, this had come to me in Dubai many years back, and this case had come with this lady who was operated on in Bahrain with query endometriomas. And when I went in, this is the image which I found. And I also thought that she was taking a lot of Dynogest and all that for very long. And this is what we found. When I went in all these areas, so I thought this is an endometrioma, but weird looking, all this chocolate material, all that. But then you keep going, and you understand where the adhesiolysis is, and do a good adhesiolysis, where the adhesions are do a good adhesiolysis. This all looked very suspicious. And after taking all this out, what I found in the end was really surprising. This was a degenerated, pedunculated fibroid. To show you in a second. So these challenging fibroids, you can see this is the uterus, and then this is the stalk, and the whole thing was the degenerated fibroid. So unnecessarily, this lady was made to go ahead and do all this. Now, another challenge is when we have any fibroid, we need to get a good scar. When you have the good scar is dependent on 3 factors. That is good hemostasis. There should be no hematomas which form in the bed. There should be less electrocautery use, and there should be good suturing. If you don't have any of these, you'll not have a good scar that can withstand subsequent pregnancy, because you should have a very good scar which in subsequent pregnancy she should not face any issues. So hence, otherwise there are other issues also. She can have antenatal rupture when she's at home. And you can have a picture like this. If a scar is not sutured properly, this is one of the reference which we had. After myomectomy, the myoma was not sutured properly, and you can see liters of pus coming out because the hematoma can form a pelvic abscess, and then you can have a poor scar, which can really lead to a lot of issues subsequently. So you can see this, which is there. This was not sutured properly and ended up having a pelvic abscess. We have many such cases coming after myoma, because everybody is doing myomectomy, but they're not suturing properly. And this hematomas which form, they are very rich. It's like putting infection in blood agar. So even these kind of infections can lead to a lot of adhesions and issues. So use less of this. And fibroids which are not removed at cesarean section, we advocated after you've taken out the baby, if you have a fibroid left, that is the most avascular time in the life of a uterus. So please take out those fibroids. Do not leave those fibroids. Of course, you have to stitch the uterus back after the cesarean, after the baby is out, and then it becomes a puerperal uterus. Then the living ligatures, the ligature-like fibers of the myometrium will not allow her to bleed when you take out the myomas out. And it's the best time to take it out. Now, this lady had presented to me with a 3.9 kg uterus 4 months after her cesarean section. I had to go in and do this. So really speaking, please, if one take-home message I can give at the time of cesarean, please take out all your fibroids. This was a case, now we've all been talking about isthmocele, where if the cesarean scar is not properly healed, not properly sutured, you have isthmocele which is forming. Similar to isthmocele, you can have a post-myomectomy scar, which can have a scar ectopic. Just like you have an isthmocele, you can have a fundocele. So this is a post-myomectomy scar ectopic. So if you don't suture properly, you can get pelvic abscesses, you can get hematomas, you can get antenatal scar rupture in subsequent pregnancy, and you can get scar pregnancy. Now, this is a scar pregnancy, which I am doing a selective devascularization bilaterally. And then taking the purse string sutures at the base of the myoma, of the scar pregnancy. And then cutting it out. Again, you should not make the same mistake as your other colleagues and suture it properly in 2, 3, 5 layers, whatever it takes. But you have to suture it absolutely properly. so that there's no dead space. We have another new method of suturing, which is again designed by Dr. Hafiz sir, and we are all following it at Sunrise, which is a flap kind of flat suturing, a flat flap suturing for myomas, which I will show you in a second. That is another good suturing technique which we're using. So suture with V-lock, it's heat resistant, so you can use bipolar on it if you have to. It's a good suture. Other barb sutures are also good, but they're not heat resistant. So this is why, and I like the needle of the V-lock, which is very sturdy needle. Take out the ectopic pregnancy like this. Sorry. So I'm just looking for a presentation. I was told last minute. Sorry about that. Just a second. Is my screen being shared?
No, ma'am. The screen share is off now.
Oh God, just a second, just a second.
Yeah, we can see your screen, ma'am.
I'm really sorry about this. Just bear with me for a second. And somehow this is not opening. I just wanted to show you the new technique of flat suturing. So I don't know why this is not opening. Just bear with me for a second. Let me just put it in this and see. Yeah. Is it visible now?
Yes, ma'am.
Yes.
So sorry about the glitch. So this is a form of flat suturing. So here you can see that normally what we would have done, we would have just taken inside out stitches and closed it. Now we want flatter, firmer scars. So what we are doing is, you can see out of this flap, the lowermost part is being sutured to the base. Okay, it'll become clearer in a second. It's a little complex, but this suturing has given us fantastic results to the extent that you can even allow her to try for normal delivery. It's such a good scar. So this is on the lower base getting stuck there. Now, one of the things which we have when we have multiple fibroids and you want to check, we do an intra-op ultrasound. I have another video of that, which I don't know why it is not uploading. I can try for that in a second, where you do an intra-op ultrasound and with a needle, I'll show you how we have ultrasound machines inside our OT to do and check for any residual fibroids. Now here with this flap suturing, what you can see is the lower flap is gone to the base. The other flap will come here, right on the base. Notice that I'm taking it from the base and then suturing it onto the other side. So these two ends, you have them pretty flattened and come here. So that's how it is. Now I'll just go quicker on that. Now when you come on and you have this flap and this flap to come in, you will take another suture and again take it from the base and overlap it. This overlapping started with OSADA for adenomyomectomy. Now we understood that, okay, if you're using it in adenomyomectomy and getting good scars, why don't we use it in myomectomy and get good scars in flap where you can have that, okay? Yeah. Sorry. So now you have another suture. You can see that vertical flap is, this flap from lower part has come up and completely taken over this side. So here, that flap is completely hidden that vertical scar. And you have an overlapping flap which has come from below up and close this. So this flap again is completely covering this area. So you have 4 layers, one layer like this and one layer like this, coming and forming the scar. So it's a fantastic scar. This is something which will not rupture, no hematomas, no nothing. And because there are 4 flaps instead of a normal 2 flap scar, which we get out of a normal myomectomy. I'd really like to invite all of you for our annual conference, Legends, going live on the 22nd and 23rd of July. And look forward to seeing you there. There are a lot more videos, lots more things, but I'm just sticking to my time because I'm getting messages that please hurry up, the other speakers are ready. And of course, our future Foxy president, Sunita ma'am, is also there. Please vote for her and support her. She's our favorite, all our favorite. Thank you.
Hi, Nikita. Wonderful, yeah. Wonderful. Always lovely to listen to you.
Yes, I think when Nikita is showing all the videos, you make it seem so good, you know, and the messages which you have given, the tips and everything are really, really so helpful. Over to you, chairpersons, to conclude the session. And then we can move here. I welcome Dr. Sunita Tandulwalkar, madam. Thank you, madam, for joining. And we are eagerly.
You know what I'm seeing is all my family here. The end of family, you feel like I have come home. I'm sitting in Guwahati, but I feel like I'm at home when I see all my favorite faces here. The IAG future presidents and everyone. I can see Sandesh, Kalyan, Deven, Sujal, Amog. Oh my God. I'm absolutely, you made my day. Lovely. Damodar, missed you on the other day. Friends, I just finished Shillong and came to Guwahati to deliver 6 o'clock. I'm starting my physical CME here.
So we'll start with you, madam, soon.
Yeah. Hello, ma'am. Welcome, ma'am. And it's a wonderful session with Dr. Nikita. And he concluded very well for the everything about the fibroids, the challenges, and the hemostasis and the scar, and tackling the how to challenges coming after the scar defect and everything. So thank you, Dr. Nikita. Over to Dr. Sandesh.
Yeah. Congratulations, Nikita. Excellent presentation. And of course, not only challenging myomas, but challenging and scary. So, but to the audience, these are very unique and rare cases which he has presented. Of course, for the beginners, there are cases which you have to select earlier, the size and the location and the numbers. But I'm sure you all will also reach to this height. So thank you, Nikita, for such an excellent presentation.
Welcome, Sunita ma'am. And you are our Foxy president. Thank you.
Let election happen, beta. You can wish me all the best luck.
We already taking as.
See, sitting in this hall, I can see the faces. Everyone has a capacity to motivate 1,000 votes, and I can count 12,000 votes here only.
Sure, ma'am.
Yeah.
Sure.
Sure, ma'am. So once again, from our side, we request everyone to vote for Dr. Sunita ma'am for the upcoming Foxy elections. And with this, we move on to the next session, that is myomas and fertility. Now that we have went through the challenges, let us throw another challenge of managing myomas and fertility. And for this, I would like to invite the chairperson, Dr. Ashish Kaye. He is the director of Asha IVF centers at Pune, at Arunachal Pradesh, at Hyderabad, Dubai, Indonesia, and Congo. He is the director of Asha Kiran Hospital and secretary-elect Pune OBGYN Society. And altogether is a wonderful person, a fun person to be with. And I invite him for this session. Our next chairperson is Dr. Vidya Bhatt, she's a laparoscopic surgeon and a fertility specialist and a medical director of Radhakrishna Multi-Speciality Hospital and IVF Center, Bangalore. She was the president of Kasoga 2017-18, joint secretary Foxy, governing council member IAG, and she has conducted more than 200 live demonstrations and trained n number of gynecologists in the art of laparoscopy. We welcome you, ma'am, and I hand over the session to the chairpersons.
Thank you, Amog, for this wonderful introduction. At the outset, I'm thankful to Dr. Komal Chavan for inviting me for this particular series. And I wish her best of luck for her vice presidential election. It's my privilege to introduce my beloved madam, Dr. Sunita Tanduwadkar. She is a past president of Pune OBGYN Society, head of the department and chief IVF endoscopic unit, Ruby Hall Clinic, advisor and consultant of Dibai Patil IVF endoscopic unit, founder, medical director of Solo Clinic
Can
IVF.
we move on? It's okay, Ashish. It's okay. Thank you so much.
And just another word for her. If you talk about endoscopy and IVF, it is an app that a person who is doing the both should talk about the myoma and infertility. So,
thank you.
Over to you, madam.
Thank you. First of all, Komal, thank you so much. When Aditi called up, I asked the topic. She said, myoma and infertility. In midnight also, I can get up and start giving the talk on myoma and infertility. I keep on changing the videos as much as possible. And let me also wish Komal all the best. The efforts what you are putting is absolutely great for your vice presidency candidature. And I wish you all the best. Friends, let me directly go to the topic. Advances in science is always for the betterment of human being. And that is what has happened in endoscopy, in infertility. Our understanding of the subject has happened. And in myoma, many things have evolved. Previously, when 20 years ago, I will say, when we were in doubt, cut it out was the dictum, and development in a surgical procedures, ease of doing it, has made many unnecessary myomectomies. We all need to understand that only 1 to 3% of the infertility patient. Suppose you tell the patient your myoma is the cause and you do the surgery and she doesn't conceive 6 months, 12 months, you are facing a trouble. So never promise that the myoma is the only cause. Always have a habit of saying that after the myomectomy, if you conceive, then retrospectively, I will say myoma was the culprit in your case. We all use this standard FIGO classification. Only this classification doesn't tell us whether we should remove or not remove. Does it depend upon the size of the myoma, number of myomas, site of myoma, or relationship of the myoma with the cavities as we do? We have to make the efforts, whether you have a sonologist or the MRI, but you need to have the mapping of the myomas, and then only you can think about which myoma, especially in infertile woman, you should be working. Evidence do say that all submucous myoma and cavity distorting myomas, repeatedly, it has been proven that implantation rate, clinical pregnancy rate, miscarriage rate, everything improves. For a submucous myoma, we call it as a type O when 100% protruding, more than 50% type 1 and less than 50% type 2. Definitely type O, probably. I'm going to show you the case where very large myoma, you are justified to do even laparoscopically. Multiple type O, again, you are justified to do laparoscopically, depends upon what patient is. And we will see how we go. Now, type O, age old, we used to do this resection. I have taken purposefully all the videos where right lateral wall, and this is what we used to do. But over the period, that is what I say, understanding of it's not only the advancement in the science, but understanding. We don't now keep on resecting this myoma. We just take a scissor and we chop it out. This myoma will undergo disintegration in 2-3 days. Just put the patient on some antispasmodic to avoid the cramps. Now, submucous myoma type 1, you can see more than 50% is protruding. All these patients, I will always say, even if it is a medium-sized myoma, that I may need 2 sittings. What happens if you don't explain the patient and unfortunately your fluid deficit is 1.2 to 1.5 liter, you wish to stop it and you explain the patient later, then patient will feel you are inefficient to remove in one go. I always tell them, I will take 2 sittings. These are rigid scopes. It's not necessarily always it is possible to hook the myomas. You can see you have to keep on taking the smaller strips. If I tell the patient I'll do in 2 sittings, and then I come out and explain them, yes, I did it in 1 sitting, and then you show them the video, they will feel, oh, what a great surgeon you are. So just your counseling helps you to create your image in minds of your patient. And that is very important. These hydromassages always helps all of us. These you can make out very well the myometrial wall and the myoma itself. Always you can differentiate. The myoma looks this whitish, yellowish, and you can very well take that out. Sometimes you need to be creative. Less than 50% protruding. I told patient 2 sitting. Infertility, I'm trying to take the similar videos. Again, this is posterior wall. What I have done is I put the hook. And I resected it so that I can put the Collins knife here. It's like putting your finger inside and hooking it out. You will see that this is a beautiful crater, the shining capsule. You remove your hand and go back in, you will find that this crater has disappeared. The myometrium contracts and leave that submucous myoma inside. It will come out on its own. Don't dilate the cervix to like 12 mm and 13 mm causing incompetent cervix. So you need to be creative. Now this myoma, it is submucous type 2. Can I call it? Yes. Now, in this, or I can call it intramural dip compressing the cavity. Now, this myoma fundal, it will not come in one go. Even if I remove, can you see there is very thin serosal wall here? Instead, I will go laparoscopically because it is causing a bulge. That is an advantage. I never get surprises. We get the same. They have told me on a right side, you have an elevation, left side is normal. You go in, you see right side elevation, left side normal. Instead of doing in 2 sittings, you be careful. But what I do is I take 100% precaution not to open the cavity. I am from a school of a girl who believes in not opening the cavity as much as. Challenges are always there. Be thankful, because that develop your strength, character. Now, large submucous myoma. Many of you here in this faculty group have seen my video. Office hysteroscopy. This is my old video of 2004. I love to show this video. See, we used to call this as an office mini hysteroscopy, not the office hysteroscopy in those times. That was a Versa scope 2 millimeter of a Johnson & Johnson, which has come. And what I'm doing is I'm showing it arising from a right lateral wall. Whether laparoscopy or hysteroscopy, inspection of the pathology, I never go with the loop in a hand. I always go with the diagnostic hysteroscopy. I examine everything. Now here what I'm doing is I'm not closing my fingers. This myoma, I know 10 centimeter. I know my speed matter. I told patient 3 sittings I'll be doing it, but I decided to do as fast as it can be. This is completely unedited video up to 50%. You will see open vessel channels. So even if you are using bipolar, there will be fluid overload, and I'm just taking a good. So give a little higher current so your loop can cut like a cheese, and from the beyond the myoma till down. Second important thing is never waste your time in taking out the pieces. I never do that. With your hydropressure, they will move. I have done an inspection. This entire cavity is nothing but the fibroid. I'm just going to keep on dissecting. You see, those pieces have moved out. And if I wait at the internal os just to assess, more than 50% of the cavity is already done, long 10 centimeter pieces, I can see I just take a right angle turn and I keep on moving till my anesthetist says, stop it. This is the only time I listen to my anesthetist very genuinely. I never say, ittu sara main kar deti hu. This case, surprisingly, we did in very one sitting. We could finish that, and that's a proud moment for all of us, taking out 10 centimeter myoma. Now, multiple myoma. Another dilemmas people have is multiple myomas. Can I give a GnRH to this patient so that the vascularity will decrease? Always go with the diagnostic. Keep on watching all the myomas. You will see that they are vascular, fine. They are multiple, fine. They are on all sides of the wall. That is also fine. Can I give a GnRH? Now you go more closer and you see those small myomas between 7 to 10 millimeter. If you give GnRH, they all will disappear. And after 3-4 months, they will come back. This is a YouTube video you can watch. I went in and removed 30 myomas without removing the hand, because I don't like to remove the hand and keep on taking out the pieces. So submucous, yes, very challenging cases, but I'm sure everyone can do it if I can do it. Subserous myoma, we know we don't need to remove them, but sometimes there can be a situation that they are giant submucous myomas, and probably you may land up in removing this. This patient is pedunculated. Can you see this? Now, what is the advantage of the mapping is not only those myomas, location, sizes, determination, they were pedunculated. I know I'm going to take it out laparoscopically. Can you see one polyp inside? I counseled the patient that, listen, I'm taking out these myomas. She has come from US. She was supposed to undergo embryo transfer over there. I told her this polyp was 1.5 centimeter. You need to remove that before the transfer. It's very important that she knows it so that her consultant over there will not tell that in India you removed the large myoma, but the most important thing was the polyp. Now you see the cervical length 5 centimeter and another 9 centimeter inside. So by rigid hysteroscope, first of all, her cervix was not even visualized even in the corner of a fornix. I would have struggled taking out this polyp. It was so simple for the people over there to remove the polyp. And I told her, you please do that job there. Now here, what happens is your ergonomics changes. So here, right, left, you have only that triangle where you can enter, but then it's okay. With the practice you can do. For me, these all fibroids are most simple fibroids. I have put up even on a YouTube this video. These are dangling. This was a 20 centimeter, but dangling means it's very easy. The other was a 30 centimeter. I'm just going, I myself is at gipisternum. I may not be able to see. But of course, even if anything, this fibroid need to be removed. At present, believe me, I have 2 pregnancies going on with multiple myomas of 7 to 8 centimeters, 6 to 7 myomas. I'm keeping my finger crossed. One is 12 weeks and one is 18 weeks. They don't wanted to remove both spontaneous conception. Let's see. Because if the fibroids are multiple away from the cavity, not compressing, you should allow the pregnancy to happen naturally. Now, 2 centimeters of a margin you keep. All the blood vessels are from the myoma. I have put up the 2 loop, so the uterine or the patient side blood flow is not there. For a 10 centimeter pedicle, this loop is not going to cause complete obliteration, but at least it will compress the miniature of the vessel. Again, don't cut too much on the serosa of the uterus. You will land up, when you cut on the pedicle, you land up in encountering too many large vessels. But you need to keep a margin for the closure, and that's why you should keep 2 centimeter, 3 centimeter away. And this third myoma was very simple. It was like a routine intramural, highly vascular, traction and counter traction, always cautery on the myoma, and then you suture it. Actually, in this case, the challenge was never the myomas. They were pedunculated, so they were quite easy. The challenges was morcellation. It is going to take you a lot of time. Actually, this was a fibroid number 3, 10 centimeter. This was 30 centimeter, and that was 20 centimeter. So this patient had given me a consent of a morcellation without bag. It was very important because she came from US. Intramural myomas, impinging on the cavity, you need to take out. And these are the pictures which helps me not only to simulate the surgery, but to sit and counsel the patient in which direction I'm going to take out 1, 2, 3, 4, 5, which myoma I'll be taking out slowly, which myoma I'm not going to touch. All that helps myself to explain. As I told you, I believe intracapsular. Can you see that from all the 3 sides? These are very small sizes, or you can say medium sizes, 3 to 5 centimeter myomas. You can see on a right side in picture, they're compressing from all sides. I'm going to tell the patient, if while removing first myoma, I open the cavity, I will go for second, I still open the cavity, I may not take out the third myoma, I will land you up in an intrauterine adhesion. Vasopressin helps us. I use for all the cases, and I close down one myoma before I go for a second so that there is no bleeding. We all know that this V-lock has made our life simple. Taking baseball sutures like a subcuticular, it becomes the material is not exposed, so it doesn't invite. If you really see, there are no bulges outside because these are all deep intramural, but I know the location. So traction and counter traction remaining within the capsule. So there's no question about opening. You can put here 100 cc of fluid also, so that the capsule get depressed more, and you examine. Even while examining, you can put a lot of fluid to see whether you have opened. And now, if you have not opened 2 times, you can go boldly for the third. Now, if you have not explained the patient that about this, and if you open both the time and you tell her, unfortunately, I opened and that's why I have not removed your third myoma, she will be upset with you that you could not do your job. Actually, these myomas are so compressing that it may happen that you can open up. Now here they are deep intramural. Take a bold cut inside. It's like a peeling the onion, make them shining naked, and then you try to do as importantly. Now these are the 3 myomas. How will I go? whether this is the myoma, which is submucous, is the culprit. When I sit with this diagram, can you see, if I remove this submucous myoma, I create a path of a least resistance for the another 2 fibroid, and over 1 to 2 months, these fibroid will start becoming apart into submucosal, and they will become a cause for a subfertility. So I will go laparoscopically and I will remove all the myomas, and I'll see to it that while taking this myoma, I will take all the precaution not to open the cavity as much, and it is possible, friends. Sometimes myomas are compressing the cavity vertically. Now, why this is important? I'll take a small incision in this case. So I may not go for a big incision because I know it is an oblong myoma arising from here and it is causing compression. I will usually on the anterior wall, I like to take vertical so that my exposure of both the walls are very good and I can do more better approximation. While on posterior wall, I take a horizontal incision. But many a time this is decided only by your location of the myoma, because your first aim is not to damage the cornea with your incision or end result of a suturing. Not necessarily these patients are for a IVF. Again, going completely, you can see now, you can see I'm taking a monopolar hook and taking out a small shining capsule. I'll peel it out and then I will dissect it out. You can use any energy source. Probably this was when I was doing a workshop, so I'm trying and showing them that it is not the energy source which makes the surgery simpler. It is wisely use of those energy sources. Traction, counter traction, making this all and coming out within this is most important. Can you see this was a complete oblong myoma as was told to me. Now you see when anterior wall, I take a vertical incision, I can expose both the walls very clearly. And I can suture in beautifully. I think I heard Nikita saying hematoma formation. I believe in that. Hematoma formation will cause always weakening of the scar apart from this pus formation because if undergoes infection. But the scar weakening will happen if there is a hematoma formation. So obliteration. So whether you need to take 2 layer, 3 layer, 4 layer, depending upon how big the myoma was, and then you keep on doing the surgeries. I'm just skipping this myoma. These are various myomas. It comes in various shapes, sizes, and location. Now, these myomas, you ensure that. Oh, I'll explain about this myoma. This patient was told by gynecologist that this myoma is a culprit and you remove, you will. She came to me for removal. I sat with her and I explained her, I don't think this is a culprit for me. Other contralateral tube is open. So you should have conceived. It is not causing much compression on your cornea. This cornea is obstructed. So I will take out this myoma and in 6 months, if you conceive, I will say that this myoma was a culprit. While here, I will try and see that my incision will be as low as possible. When you take an incision exactly in the front, it is very easy. But if you are going down, because I want to be away from the cavity, can you see the 4 diagram, the end result? The corneas are so up and I just pushed entire fibroid in front and then I removed. Suturing sometimes become difficult. You have to really push, or if you are lucky, you can antivert uterus beautifully. But look at this. The incision should be so much away that your end result is beautiful, clean pelvis. And if there is no other factor and it was not unexplained infertility, this patient should conceive. So prepare yourself well before each surgery to excel your performance. Chase the excellence every day. Now, these myomas, because of their mammoth size, they are going to give us a trouble. I explained the patient, I'm going to take out these 3 subserous type where I can see the bulge. Laparoscopically, there is no tactile sensation. So the 4th one, I'm not going to take out. This patient was a Google red. She said, look, doc, I came to you not for these 3 myomas. I know you will remove them. I came to you because I want this fibroid. Otherwise, in 3-4 years, this will become again 4-5 centimeter and I'll undergo surgery. I love to pamper my patient. I never say no to my patients. I always think myself sitting in that chair. If you are fast within the vasopressin action, you remove first myoma, you suture that myoma out. and then you go for the next myoma. You take out monopolar hook, makes no difference, good monopolar and bipolar, and you can see you sutured both the myomas. Now you can antivolt this uterus. You remove that myoma. My Manoj Chinchwadkar, I asked him after the patient's demand, where is the second myoma? It's not having bulge. He said me, go 2 centimeter low and 2 centimeter to the left. Can you see that? I just sutured with the Vicryl 2 stitches, that 2 centimeter. I went 2 centimeter. I could not palpate anything. And then I took a bold incision, believing in him, and we got the myoma, and you take out that myoma as well. So friends, sometimes this is a large anterior wall myoma. We all know we will go in. I will see first the cornu, left side, right side. I have seen the cornu. Now the thing is, my incision should be not disturbing the cornu, and I do this white rangoli. If I would have taken a central incision, I would have enucleated, wasted lot of time, and then closure of this bed itself would have taken. If I take up 5 centimeter above the fundus and from all the side inverted U incision, always have a habit of making this white rangoli, especially with the large myomas. When you start cutting, your direction may go haywire. But this white line, how the footpath, the white marks help us to drive the same way I like to do in all my myoma surgeries. And I'm taking the cut. Once this white rangoli, I decided 5 centimeter above, the cornal opening is down, you take out, and you take that redundant wall also out, and your closure becomes a simple. You don't have to struggle with the cavity. Sometimes you can't see the myomas, all bulge, previous laparotomies for endometriosis, open myomectomies. This patient is obviously for a IVF. But unless you take out those deep intramural myomas, you can't give them a pregnancy. And after going in, I can't see the myoma at all. We do the bowel preparation because of previous laparotomies. Obviously, the small bowel sometimes looks like a thin, flimsy fibers. Be very careful. All incisions should be always on the uterus, on the serosa. Avoid energy source, better Caesar, and create the plane. Push the uterus than pulling the bowel. You started seeing the fibroid. Don't jump for myomectomy. You will remove the myoma. You will not have a bed for a closure, because once the myoma is out, this adhesiolysis will be very difficult. So you spend more time in adhesiolysis and making your anatomy normal, because it is not, myomectomy is simple, incision, enucleation, and closure. What will take time is your complete adhesiolysis, unless I remove. Otherwise, this bowel loop will be in the flap, and they will come into small pricks. You can put the vasopressin, and you can give a little bolt cut. Choice is yours. She has associated hydrosulfing. We all know that unless I remove the hydrosulfing, I will not be able to give us justice. So I'm just opening to see where the ureters are going, because it was not possible for me to trace, and they were extremely to the lateral wall. I don't have to bother. I can boldly remove the hydrosulfings first, and only when I can see now complete uterus, I will be doing the myomectomy for this patient. So it's very important that you struggle doing everything. And then these are the myomas. Can you see that? Now I know I have the beds to close. She had one right lateral wall, which was impossible to see. You go from the virgin area anteriorly. My people were exhausted. They said, ma'am, itna badhiya hua hai, stop it. There is no fibroid. I had to believe my sonologist. We have to see that there was a myoma that was more compressing to the right lateral wall. I need to take that out to give a success. So friends, dilemma is intramural myoma not distorting the cavity. Does it affect the fertility? 5 centimeter myoma to 1 centimeter away from the cavity, whether it will be. And this is a beautiful paper by Sankara, because I also believe in taking out all myomas more than 5 centimeter, which are intramural, whether they are compressing or not, before the embryo transfer. Because in India, we are compelled to do the success in a very first cycle. She may not have enough embryos to give a trial and error. Even 1% doubt in your mind, cut it out in IVF cases. This meta-analysis boosts your energy 6,000 plus cycle, and they have shown that in non-cavity distorting myomas do affect the live birth rate, clinical pregnancy rate, and you should be taking out. So friends, myomas comes more and more you do, more and more challenging cases it comes. Surgery at any age group is uncomfortable, and our job is to make it comfortable, not by doing it laparoscopically, but by selecting wisely which woman needs to remove the myoma and which woman will not remove. Just don't do it for the sake of doing it. Treat every patient as your own sister. If you have not removed her, please don't remove. In infertility, individualization of a case is important to give the results. And I appeal to all of you to bless me for my Foxy presidential candidature. The elections are in August, 1st August to 10th August. Friends, I need your support, and I always like to thank my each and every residents and fellows. I think over period, they made me more wiser with their questions and with their assistance. Thank you.
Thank you, madam. As usual, it is a what do you call is a just like seeing the movie when you are operating. You cannot able to go away from the screen. It's keep you motivating and keep you thinking the steps what you are doing. It can be replicable for all of us, and it's such a topic that you make us think that which fibroids to be removed and which fibroid not to be removed. And secondly, madam, today what I learned that whenever there is a submucous fibroid, you can leave it, just cut the base, and by the uterus by action it will come out.
Actually, now because of elections, I have no time. I have such a beautiful where I give an incision on a submucous myoma, how we do laparoscopically, I do hysteroscopically, and I enucleate the myoma, which are type 1, type 2. You just give a beautiful, nice incision and it pops out beautifully. I will do that after August. All video recording. I have amazing cases lined up in last 4-5 months, and I really wish to edit out all of them sometimes.
And secondly, madam, the important message to all of us that the sonography and mapping of the fibroid is much more important, because that gives us a pre-operative evaluation of the fibroid and how we can approach the each and every fibroid.
I feel in laparoscopy, there is no tactile sensation. You have no choice than to do the mapping either by sonography or the MRI. At the same time, mapping helps us to counsel the patient and also helps us to decide the direction and in which sequence you will be taking out myomas, which myomas you will not be touching also.
And last, madam, I like the word rangoli. White color, and that gives us a precision about the incision.
You all are expert endoscopists here. You imagine when it is a large 30 centimeter, if you just start cutting, sometimes the down assistant keep on pulling the cervix and diaphragm. The above assistant wants to give you good exposure, so he pushes the fibroid in a different direction, and you realize your incision gone wrong. So I do always white rangoli, and I follow the path of that rangoli.
And madam, as rightly said by you in the beginning, it is like a IIG family, and each of us are there for you, and hundreds of us.
That I love.
And my friends are really vouch for you that we are definitely going to support you, and we are going to see you as a president of.
No, you all are working. Amey also is making that Maharashtra group. Amey keep that active, keep on discussing, keep on putting. It helps me. And whatever interesting your videos, I keep on posting on other groups also. I think Kanojia's one suturing skills. It was so fantastic. I posted and everyone is appreciating. So I'm helping you to reach out to the country. Nikita, thank you so much. Thank you, dear. She's always openly supporting me. And I'm each and every one of you. I'm thankful to all of you. I have no words. I feel like I come home when I see you all. Because I'm moving to the different places many a time. I don't know the gynecologist. When I went to Warangal, I knew only 2 people. The mob of 100 is so unknown. So sometimes it's nice to come to your own family.
Thank you, madam. Thank you for your speech. Thank you. Over to Aditi.
Yeah. Thank you. Thank you so much, Sunita Madam, for that very enriching talk. It's always a pleasure to hear from you. And I urge each one of you to support her for her Foxy presidential candidature. I also urge each one of you to support Dr. Komal Chavan for her Vice President Foxy candidature.
We will work together. I believe. I believe. Komal will work together and rock.
Yes, thank you so much, Dr. Sunita Madam, and thanks, Aditi. It was a lovely session, and I think Ashish has pointed out really the good salient take-home messages. Thank you so much, Ashish. And over to you, Aditi and Amok.
Thank you, Komal Madam, and wish you all the best.
I have to start my lecture. Can I leave?
Yes.
I want to. I may give that YouTube link for to post on all the groups.
Yes,
Suturing technique. Give me.
Yes, ma'am.
Thank you.
We'll now move on to the next talk. It's on suturing techniques and laparoscopic myomectomy. The speaker is none other than Dr. Ameya Padmavar, and I would like to invite our esteemed chairpersons, Dr. Deven Jogal. He is a director at Jogal's Women Hospital, Bhuj at Kutch, and he's an advanced gynec laparoscopic surgeon, and was the head of minimally invasive surgery at Adani Medical College at Bhuj. Welcome, sir. And Dr. Damodar Rao, he is a consultant endogynecologist and a reproductive medicine at Rao Hospital, joint secretary of DNIAG and managing committee member of IAGE, and also the recipient of the Shah Ratnam Young Gynecologist Award, AOFOG. Welcome, Dr. Damodar. Requesting our chairpersons to call upon our speaker.
Devanikan.
Yeah. So I would like to welcome Dr. Ameya Padmavar sir, and I feel it is very good chance for me to introduce him, because I always see him as a guru, because many times, so many times he's behind the curtain, but he's guiding us a lot, and he's very innovative. He, as I said, he's most of the time behind the curtain, but he's very innovative. He has very good skill. And we still use, I still see his videos from whatever videos he has sent to AGL or the different European Society, in European Society as well. So I would like to introduce Dr. Ameya Padmavar, and he is excellent laparoscopic surgeon, gynecologist, and faculty at EMAS and EISE, International Publications. He has got many, and he has designed and developed first indigenous surgical smoke evacuator. And he's from Kanyaka Women's Clinic, Mumbai, India. So welcome, Dr. Ameya Padmavar sir, and over to you, sir.
Thank you. Thank you for the kind words, Devin. And before I begin, I thank Dr. Damodar Rao, Dr. Komal Chavan, and Aditi for this opportunity. So I'm going to discuss the suturing techniques in laparoscopic myomectomy. Can you see my?
Yes, we can see, sir.
Okay. So we start with this topic. And after seeing all these interesting videos and all the surgical techniques which we have seen, we boil down to one concept, that why do you need to do the suturing? Suturing is important for the wound closure and restoration of the myometrial integrity. Sometimes it is used to retract the bowel loops if they are coming in the way, for enhancing the surgical exposure. And at times it is used to put temporary ligatures on the blood supply to the uterus, the uterine, the infundibulopelvic ligament, to reduce the myometrial perfusion and allowing us to get enough time for surgery. So there are certain prerequisites when you want to do the suturing. First is the surgical and the vascular anatomy has to be evaluated before you embark on the incision and start doing the myomectomy. One has to have the skill set for intracorporeal suturing. The port placement and the ergonomics has to be suitable, because the way you don't want to hurt the patient, you don't want to hurt yourself by having abnormal positions. And most important is the basic essential suturing technique. If you have that, yes, you can do the surgeries like myomectomies and pelvic floor repairs. And of course, we cannot ignore the sutures. The sutures which we commonly use is Vicryl or polygalactin, PDS or barbed sutures. So let's see what we need to remember, that the ideal position for good ergonomics is when we are looking down at the monitor with a angulation of about 10 to 15 degrees and our elbows are at ease and they are not at right angles or flexed, and the foot pedals are well positioned. So here you can see the two pictures in which in the first picture you have the surgeon who is with his elbows partly extended, the neck is at rest and he's looking well at the monitor. And another condition in which his neck is extended and this is a strenuous position. So you have to stick to this type of position while you do the surgery so you can do a good job. The next is the port placement. Now these are the commonly placed ports, the umbilical port being the visual port, and now it depends on how you are going to do the suturing. So your port placement, if you are going to do ipsilateral suturing, the port placement would be on the side where you are standing. So this is how. So if you draw an arch from the primary port to the anterior superior iliac spine, all your ports will be along this arc. So for ipsilateral, you will have these two ports. For contralateral, you will use the port on the opposite side, or sometimes you may use this port and the left lower port for contralateral suturing. And sometimes, if you are acquainted with the use of suturing from the suprapubic port, you can use the central suprapubic port. Okay, sometimes it is closer to the primary port. Depending on the size of the myoma, the position of the primary port will vary and it will be higher up as the size increases. The suturing angle, this is very important, that how are you going to suture. So the suturing angle is of crucial importance. So if it is an acute angle as in ipsilateral, you should be aware that there will be certain challenges posed. It is best when you're doing contralateral suturing, as you rightly saw Dr. Nikita and Sunita madam demonstrate, that by contralateral suturing, it is extremely easy to close the flaps. So this will, this will be a obtuse angle. And at times when you use the suprapubic port, the angle for suturing will be more or less 90 degrees. So the complexity of the suturing technique will be based on the ergonomy. So if the angle increases, the ergonomy will also improve. So remember this and use the technique which you are acquainted with when you're going to close the myoma flaps. Otherwise, you will burn out and get tired and exhausted. Next is, what needles are you going to use for your closure? So the needles which are half circle are the ones which are most useful. Okay, sometimes for very thick myometrial flaps, you may use a 3/8 circle needle. This was available once upon a time, and we used to use the number 1 Vicryl with a 3/8 circle needle, but these are no longer available with the company. And very rarely, but I have used it only once, the straight needles for really thick flaps. Next is the suture. The suture, you have to be very choosy when you go for the suture. You need to know what size you're going to use. That is the caliber of the suture. Normally number 1 or 1/0 metric suture is used. You should be aware of the tensile strength. A little more force, or sometimes you can have the tungsten of the needle holders cutting through the suture, and it can get frayed and it may break while doing the surgery. The next is, for how long is the suture going to stay? Because you have to tell your patient when she can go for her fertility treatment, whether it is monofilament, whether it is multifilament suture. You should be aware of the stiffness and the flexibility, because when you're using PDS and the barbed sutures, these are the challenges for knotting which are to be faced. And the surface characteristics, of course, the monofilament or the barbed suture. Because of barb suture, the incline has been more towards the monofilament suture, because barb sutures are created from monofilament sutures. So the most important breakthrough in suturing was the invention of the barb suture. Now for barb suture, it is a knotless suture strand, and you don't need to be competent, or you may need not put a knot at the end of it. Okay, what happens is the barbs impinge or get tangled in the myometrium and apply uniform tension around the myoma bed, and this is very important in preventing the myometrial integrity, and the incidence of hematomas, intramural hematomas, has significantly gone down. So how are these barbs prepared? So you use a monofilament strand, and then you have these cutting wheels which cut small scallops into it, and you have these unidirectional barbs which impinge in the tissue. They will move in the tissue easily, but will not retract backwards. Okay, so this is the common barb suture, which is in which the barbs are situated in a spiral fashion along the axis of the suture. This is V-lock or most of the other barbs. And sometimes you can use symmetrical barb sutures. These are unidirectional and they are asymmetrical. So the symmetrical one is known as Stratafix, which is made by J&J. Then we bring our attention to the instruments with which we are going to do the suturing. That is the needle holders. They may be Ethicon handle, the axial grip or the pistol grip. The handle is very important because you can do the rotatory movements with an axial handle. It is a bit difficult with the pistol handle. They can be with a straight jaw or a curved jaw. There is something like the self-writing needle holder. These are not good for suturing myoma beds and should be avoided. Okay. So laparoscopic suturing is a skill science, and it is based on certain factors. One is the depth perception. So the better the vision you have, such as with a 2D high definition camera system or with a 3D, it becomes easier to do or take the suture. Even when we were teaching students do suturing in IMAST, I noticed that the suturing time reduces with the better vision of 3D. The rest depends on the to and fro movement, the rotatory movement, which is dependent on the movement of the wrist, and the tipping movement. So these are important while tightening the sutures. And all this goes on in the brain first, and then it's executed. So practicing the suturing is very important before embarking on laparoscopic myomectomy. Of course, a squared knot is very important, but the commonly used knot is the surgical knot. This is going to be demonstrated in the videos which you will see soon. The symmetrical barb sutures, as I mentioned, this is the commonly used ones. Again, it has a half circle needle. A 30 or a 40 millimeter needle is what we want. Okay, so this is the Stratafix. This is the code which we use. The commonly used polygalactin codes are the #1 Vicryl or #1 polygalactin with the code 2347. If you are using suturing to approximate very thick myometrial mantle, then you have to use this code, which is 2421. It is a reverse cutting half circle heavy needle. So this is very important, and it really reduces the time of suturing. We have been hearing about the barb suture by the name V-lock. Most of the barb sutures are made of PDS, but V-lock is a polyester of glycolide, dioxanone, and trimethyl carbonate. This makes it very resilient to heat. So you can use the electrosurgery to seal certain vessels at the end of surgery without damaging the suture integrity. And the number in the code of V-lock, you have something V-lock 90 or V-lock 180. That refers to the number of days it takes to actually get absorbed. So 180 refers to 180 days. So for 6 months, it is required for the suture to get completely autolyzed. Okay, now let's come to the suturing techniques. The first suturing technique is known as the layered closure technique. So you have a crater when the myoma is out, and this is the way you do it in one go. So you have a strand of suture which goes at the base of the myoma bed, comes back again and intervenes or goes through the flap at a higher level. So it is basically in one go, you're doing a two-layered closure. Okay, we'll see in this video subsequently. So here we are removing the myomas. And once the myoma bed is out, you plan the suturing. Now, while doing the suturing, this is the contralateral technique, which I am demonstrating here. So this needle is the one I was saying. This is the 3/8 circle reverse cutting needle. This code is 2422. And you take a deep bite at the base of the myoma bed, and that's the first bite. Then again, you rehold the needle and position it. Pull out the strand, and the next bite is in the same line, but at a higher level. So in one suture, you're going to reconstruct 2 layers and reduce the incidence of intramyometrial hematomas. So the apposition is going to be great, and the serosa is going to come together in a very miraculous way when you do the closure. And a series of interrupted sutures like this is going to help in apposing the myoma or the serosa lying over the myoma in a good way. So if the serosa comes together well, you will have less post-operative adhesions. The lesser amount of electrosurgery on the myoma, it's going to heal better, and the scar integrity is going to be superior. So as you can see, because of the better angulation of the tissue by contralateral suturing, the suturing is excellent and it is stress-free or effortless for the surgeon. So you may take 2 or 3 sutures of this sort to close a bed of this width. So this was approximately a 5 centimeter myoma, and you can see that the contour of the uterus is restored. The next, now you have enucleated a myoma and you've got a big crater. So the challenge in these cases is to prevent the collection of blood. Once the effect of vasopressin or whatever temporary uterine artery ligation you have done, once you reduce it, the hemorrhage can collect in the myometrial mantle and cause a hematoma. So to prevent that, you take a horizontal mattress suture at the base of larger flaps. Okay, so here you take it. For this, one additional skill is required, that you have to be ambidextrous. The needle has to be driven from the right to the left and from the left to the right, so that you can knot it on one side. So I'll demonstrate it in a video here. So here we have removed the myoma, and that's the bed, and the reconstruction is happening. You can see that the myometrium is very, very thick, overlying this deep intramural class 4 myoma, and the whole thickness has to be taken care of. Over here, we are going to use the half circle reverse cutting needle. This is the 2421 suture code. So this needle is extremely strong, and it never straightens out. And basically, it is a OS needle. The foil will have the alphabet OS. OS stands for orthopedic surgery. So this needle is cut out of a steel rod. So it never straightens out. It's not a needle which is straight and then bent into a curved needle. So this is a very tensile needle, very good for closure of large, thick myometrial mantle. Mind you, this does cause damage to your needle holders, and sometimes the needle holders break when you apply too much force. Another peculiar thing I've seen when these needle holders are handled is when the jaw breaks of the needle holder, it is always the straight jaw. This is the jaw which always fractures, and it gets flung in the abdominal cavity. So here you can see we are using the ipsilateral knotting technique, in which we are knotting the box suture or the horizontal mattress suture. The advantage of this knot is that you have the layers of the myometrium coming close to each other, and they are going to aid in the closure of the layers after that. Sometimes the first throw has to be stepped by the assisting surgeon so that the knot is well secured. After doing this box suture, sometimes the density of vessels at one of the angles of the incision is more. Then you have to take a simple stitch with polygalactin to close these sutures. So that gives you enough time for closure by the technique which is commonly known as the baseball technique. So this is at this angle, you can see there is blood which is oozing out from these edges. So you have to take a deep seated. Again, in this odd position, you see that this needle is really useful. The OS needle is a great boon, and it can be used to place the knot. When the knot is of a shorter or the loop of the thread is very small, use the length of the needle to take the throw. The moment the needle holder starts going away from the base, that is the knot side, you please release it and rehold and apply the traction. So that is how you would go. Okay. So the next technique is the figure of 8 sutures. Now this is the commonly used suturing technique used for myomas which are smaller and when you do not have access to barbed suture. For multiple myomas at different sites, this is a very useful tool, and the whole layer or the whole thickness of the myoma bed can be taken care by this suture. This is the code 2347. Okay, so you can take a figure of 8 suture and secure it by 2 or 3 such sutures, and the myometrial apposition is achieved. So that's the next technique of laparoscopic suturing. The next one is known as the inverting seromuscular sutures, which is executed with the use of barbed suture. Now this case is basically a low set cervical myoma. We have enucleated it from the anterior aspect, and the oozing is persistent in spite of the uterine artery clipping and the vasopressin. So that just proves that there is alternate blood supply to the uterine torus and the cervix. So in the region where the density of vessels is higher, you can place a simple figure of 8 suture, but the incision is wide and you have to start closing it with seromuscular sutures so that the longer flaps can be apposed well. So here we are using a symmetrical barbed suture. Okay, so this is like a fish bone, and the barbs are in a symmetrical fashion, and they are very useful for apposing larger flaps of myometrium. So here I'm just taking the simple sutures because here the myometrial thickness is lesser. As the thickness increases, one has to modify the technique, and that technique is known as the seromuscular sutures. So these are exactly the way you do the seromuscular suturing of the bowel or the bladder. In the same way you take. So what happens is the layers of the myometrial mantle get interned and they compress into the bed and don't leave any dead space, preventing intramural hematomas again. So here you can see the bite is taken close to the edge of the incision and brought out far away from it. And as you go on tightening it, you can see the uniform compression of the myometrium. Here you go from further away from the incision edge, bring the needle out from close to the incision edge. On the other side, you take it close to the incision edge and far away. The net result of this is extremely rewarding, and there is good serocell apposition, and there is almost In my whole series of myomectomies, I've never had a intramural hematoma or an abscess after the use of this seromuscular inverting technique. So this is a useful technique for closing larger incisions and deeper mantles. That's the final result. You can see as we do the suction of the blood. In this case, we had done the uterine artery ligation by the shoelace technique as described by Dr. Pranay Desai and Sanket Pisat. And those ligatures were also released at the end of the procedure. You can see that the release of this ligatures is extremely easy. You just pull in the and out comes the suture, restoring the blood supply to the uterus in a very efficient way. That's on the uterine artery. You pull the small strand and you can see the uterine artery starts pulsating again properly. So that is very important for the patients who desire future fertility. Last is just to mention, which you have already seen Dr. Sunita Madam do the baseball suture, in which the bed, the myometrial bed is closed with a suture which is taken from outside in on either side of the incision. So outside in, outside in, outside in, outside in, and you get good apposition of the serosa. So I think with this, I have covered all the techniques for myometrial apposition by laparoscopic suturing. Thank you for your patient hearing.
Thank you. Thank you, sir. Yeah, Damodar.
Thank you, sir. As always, very practical, to the point, very nice points you brought out in all your videos. Just a couple of questions. So do you always, I do contralateral sometimes, ipsilateral sometimes. There are people who only stick to ipsilateral, or people who only do contralateral. What is your take on this? Or
see, as I said, the technique which you are acquainted with is the one which you should practice well, and you can achieve all sorts of suturing with each of them. Only thing is you have to work on the ergonomics. Your table should be, very low, and you should have a good steep Trendelenburg. Then it is possible. I have grown from contralateral suturing to suprapubic and now to ipsilateral. So any incision, like you saw, the vertical incision on the posterior wall is also possible to appose by ipsilateral suturing. You don't place a myoma uterine elevator in the uterus, so you can tilt the axis of the uterus to suit your, direction of suturing.
Thank you, sir. Devin, any questions for sir?
Thank you very much, sir, for an excellent presentation and elaborating and throwing lights on the one of the most difficult thing in myomectomy, because enucleation of myoma, I think it is not difficult or it is not an issue, but usually the problem and the issue is suturing. So thank you so much, sir, and over to Dr. Aditi.
Thank you, Devin.
Thank you, sir. Thank you, Dr. Ameya Padmawar, for that amazing lecture. And I have to say that sir is such a great teacher. I visit IMAST as co-faculty when he is the course director, and he's an absolutely great teacher. So we've had some very phenomenal talks from Dr. Nikita Trehan. In fact, Dr. Nikita Trehan I've gone to her for my fellowship. So she has given me my first myomectomy and suturing. So it's extra special for me. We've had a myriad of fibroids so skillfully managed by Dr. Sunita Tandulwarkar, and that very technically sound lecture by Dr. Ameya Padmawar. And I'd now like to hand over the mic to Dr. Amog Chimote for the panel discussion.
Okay, so after a spell time talk by Dr. Padmawar, let's move on to a broad spectrum topic that involves the ABC as well as the Z for leiomyoma. The much awaited panel, for which I would like to invite the moderators, Dr. Kalyan Barmare sir. He is the Secretary of IAG, Chairperson Infertility Committee AMOX, Executive Member of MSR, Chairperson Public Awareness Committee of FOXY, and a very bubbling and a good person to be with. We welcome you, sir. Our next moderator, Dr. Sejal Naik. She is a GEM member awardee of IIG 2022 Best Favored Award in All India Congress. She runs, she is a consultant gynae endoscopy and IVF specialist at Delhi Love Women Care Hospital at Surat. And she runs IIG and Foxy recognized training centers for gynae endoscopy at Surat. We welcome you, ma'am. To guide us, I would like to invite the teacher, the mentor of mentors, Dr. PG Paul, sir. He's the chairman of Paul's Hospital, Kochi, India. He's the board member of ISG and elected member of the Society of Reproductive Surgeons since 1997. He has trained more than 1,800 gynecologists in gynecological laparoscopy, and he's one of the most senior and learned professor and teacher for us all. We welcome you, sir. Now, moving on to the young guns, the torchbearers of endoscopy in India, I would like to invite the panelist, Dr. Sujal Munshi, sir. He's a consultant gynae endoscopy surgeon at Concept Clinic. At Nova IVF Ahmedabad, PS Medical College, and HM Patel Center, Karamsad. He's the honorary treasurer of IIG 2023-24. We welcome you, sir. Our next panelist, Dr. Yashodhan Deka, the endometriosis warrior. He's done his advanced laparoscopy fellowship in Kochi and currently a consultant laparoscopy surgeon at Nalbari Maternity Hospital and Sarthi Hospital. And he's known for his live endometriosis surgery all over Facebook. I welcome you, Dr. Yashodhan. Our next panelist, Dr. Subhash Malya. He is a chairperson of Foxy Endoscopy Committee 2021-24. He is a member of Specialist Board, National Board of Examination, chairperson of Medical Legal Committee for KFOC, and a secretary Calicut Society from 2022 onwards. We welcome you, sir. Dr. Dhaval Bakshi, he is a SRA certified reproductive endoscopy surgeon, gynecological endoscopy surgeon, and fertility specialist at Disha Fertility Center and Motherhood Hospital, Indore. He has been trained at Eva Hospital, Ahmedabad with Dr. Deepak sir, and a gold medalist at MCH Reproductive Medicine and Surgery. We welcome you, Dr. Dhaval. Our next panelist, Dr. Surakshit Bhattina. He's a FICRS scholar from USA. He's done his fellowship in minimal access surgery from France and India, and is a fellow in reproductive medicine from UK and fellow in cosmetic gynecology from UK. And he's the founder of Indigo Women's Center. We welcome you, Dr. Surakshit. Dr. Tarun Joseph, he's an obstetrician, gynecologist, and endoscopy surgeon, consultant at Joseph Hospital, and fellowship in minimal access surgery, diploma in advanced laparoscopy, surgical anatomy, and his special interest is in high-risk obstetrics. We welcome you, Dr. Tarun. Dr. Amit Tajne, he is the executive member of Foxy International Academic Exchange Committee and a joint secretary of Nashik OBGY Society, faculty in many conferences, workshops, and medical director at Archit Hospital. We welcome you, sir. Dr. Gaurav Desai is an assistant professor at St. J.S. Medical College and KM Hospital, and he MOGS managing committee member and joint assistant secretary of Journal of OBGYF India. We welcome you, Dr. Gaurav. Dr. Shrikant Ori, he has done his fellowship in gynae and laparoscopy surgery from Israel. He has diploma of minimal access surgery from Oldenburg, Germany, and postgraduate diploma of medical legal system. We welcome you, Dr. Shrikant. So with this, we finish all the panelists, and I would like to hand over the session to the moderators, Dr. Kalyan and Dr. Sejal. Thank you.
Welcome, everybody. There are who's and who's of endoscopy here, all young guns. So we are going to restrict to a few topics which are being not covered in the previous talks. So firstly, as everybody knows, there are advantages of laparoscopy like lower blood loss, decreased pain, shorter hospital stay, faster recovery, and fewer wound and bowel, and low thrombotic complications. So everybody knows fibroids are benign tumors. They are tumors found in women during reproductive age group. Incidence is around 20%. They can be subserosal, broad ligament, transmural, submucosal, and pedunculated. The need to treat submucosal fibroid is widely accepted fibroids affect implantation and fertility, and stratifies their impact on basis of size, location, and nature. They cause alteration of uterine contraction, cytokine factors, genetic factors, HOXA10 and HOXA11 gene expression might be associated, and there are alteration in endomyometrial junction zone. So everybody knows this FIGO system, where 0 is pedunculated, 1 is less than 50%, 2 is more than 50%, and hysteroscopic myomectomy is not the part of today's talk. We are going to discuss about FIGO L2, L3, and L4 lesions. So my question to all panelists, removal of asymptomatic myoma, what size of asymptomatic fibroids needs to be removed? We'll start from Dr. Subhash. Dr. Shrikant, you can take this.
Yeah, so what size, like if it is asymptomatic and it is more than 4 centimeter, and so then only we can look for any operative procedure if we have to do. And what was your question again, please?
What size of asymptomatic fibroids needs to be removed?
Yeah, if it is more than 4 centimeter, we should go for the removal of the fibroid. So
Dr. Dhaval, you agree with this?
So actually it depends upon, so usually asymptomatic fibroid, if we're talking about a woman with infertility, so then if it's an intramural fibroid, if it's more than 4 centimeters, then definitely yes. If it is a subserosal fibroid, anything more than 7 centimeters, or something that you feel that might be located at the cornu and disrupt the tubo-ovarian relationship, those fibroids should be removed. But if it is just an asymptomatic woman with absolutely completed family, everything, we can just monitor and observe and just see. As long as it is not causing any mass symptoms, nothing, there is no degeneration, nothing, we can just keep on monitoring.
So Dhaval, for you, this lady is 35-year-old, para 2 living 2, TL done. She has gone for an insurance checkup where there is a 10 centimeter subserosal fibroid. What is your take on this?
The 10 centimeter subserosal fibroid is quite a large one. So ideally, because we all know that
asymptomatic.
35,
yeah,
currently asymptomatic, but she has to be counseled that later on, if she, if the fibroid undergoes degeneration, or if she starts to have some mass effect, many of the times actually, before they don't know that they have fibroid, they will be asymptomatic. But the moment they know that they have a fibroid, then all the symptoms they will start, then she'll start becoming symptomatic on her own and start feeling mass symptoms, etc., etc. So we just have to counsel her that these are the problems. She's 35 years old. It is definitely going to increase in size. If, within 10 centimeters and all, it can be done laparoscopically quite easily. But if it grows beyond, maybe she might need a laparotomy, and then just leave the decision upon her. But also always counsel her that to get an ultrasound done once every year, and just to see if the fibroid is growing very rapidly, then that is also an alarming sign. And if she develops any pain or any other symptoms, then definitely then it has to be removed.
So Dr. Subhash, what is your final take on this issue?
Sir, I completely agree with what Dr. Dhaval had said, that in case if the size is bigger, sir, definitely yes. But of course, if you go by the literature, earlier it was about 5 centimeters, now they've cut down to 4 centimeters. But again, if it is a case of infertility, as he rightly said, definitely yes, our threshold for a surgery will come down, more so in a long-standing case of fertility. But otherwise, symptomatic patients, yes, we would definitely go for a surgical aspect, sir.
So those patients with asymptomatic fibroids, if they become infertile, there is a menorrhagia, there is a pain or pressure symptoms, these are the patient, or rapidly growing fibroids where they do yearly checkup, needs a surgery. Those asymptomatic fibroids, as everybody has rightly said, more than 4 centimeter intramural or more than 7 centimeter subserosal may require surgery. So Dr. PG Paul, sir, the final take by expert. PG, sir. Dr. Sejal, PG, sir, has joined?
Yes. Sir has joined.
Yeah, sir has joined, sir.
PG, sir, I'm audible to you? Okay, removal of asymptomatic patients to improve fertility. This practice committee of American Society of Reproductive Medicine paper, which says myoma reduce the likelihood of achieving pregnancy. Myoma size, number, and location is associated with reduced likelihood of achieving pregnancy or increased risk of early pregnancy loss. Grade C evidence. Removal of subserosal fibroid improves fertility. Myomectomy reduces miscarriage rates. And there is fair evidence that myomectomy doesn't improve reproductive outcome, that is clinical pregnancy rate, live births following ART procedure, that is grade B evidence. So now this question is, if these are the pedunculated fibroid, how to go about it? Dr. Shrikant, for you.
Yes, sir. So pedunculated fibroid, if it again, it depends on the size. If it is very big, we have to remove it because it can again, there is torsion. It can again get torsion with another adnexal tissues also. So again, the size more than 7-8 centimeter has to be removed.
Okay, so can you just elaborate about the technique of removal of pedunculated fibroid?
So for pedunculated fibroid, if it is again, we can just go inside and either if the base is broad, then we can use the vasopressin and use the vasopressin on all sides, and then we can cut it with the scissor or with the harmonic device. And once the base is cut, if the the serosa,
so you are going to use a bipolar cauterization every time. Are you going to, when are you going to use sutures for the base of the pedicle?
So if the stalk is not very big, we do not need to use sutures to approximate the tissue. But again, if we have the serosa is cut too much, then again we have to reduce the raw area. So then only we use the sutures. Otherwise, there is no need for suturing. So like the photo you have shown, you again in this we have to.
Yes. Now to Dr. Sujan Munshi, what are the tips during myomectomy you are going to tell everybody in crisp 5-6 words?
In this intramyometrial. So basically, whenever we are planning myomectomy, our aim, especially in infertile patient, is to remove as minimum the myometrium as possible, to do least thermal damage to the myometrium and do good approximation. So there are various means of reducing the blood loss. You can use vasopressin, one of the most commonly used agent. You can also go for, in selected cases, you can go for bilateral uterine artery ligation at origin, but in patients of infertility, should be used very judiciously or temporarily. Third is you can also use hypotensive anesthesia to reduce the blood loss. Second is while putting the incision, it is individual surgeon's choice, but try and use minimum energy as possible. If at all you are using monopolar pure cutting current, it has to be on the lowest possible setting and on the pure cutting current only. People use harmonic also or mechanical scissors also to open the myoma scar. Preferably less number of scars are preferred on uterus. So if it is a single fibroid, choose a site where you can justify the suturing in best possible way. Transverse, oblique, or vertical is purely surgeon's choice, and we have seen with number of cases that it hardly matters if proper approximation is being done on the site of opening you choose. And keep on changing the myoma screw application. Myoma screw is one of the best instruments to apply traction. Keep on changing the myoma screw site for proper dissection. And if there is a lot of vascularity in the base, you can simultaneously use precise bipolar. And I think suturing, you can use delayed absorbable suture material. Nowadays preferred is barb suture, but you can use extracorporeal or intracorporeal using a Vicryl also. So, but be very sure that there are no dead spaces left for hematomas to grow. So proper approximation is very, very important. And if especially you are using barb suture, lot of exposed barb inside the peritoneal cavity is not right. So use a good basketball suturing technique with minimal exposure of the barb in the peritoneal cavity.
Very rightly said. You have covered almost all points. Anybody wants to add, Dr. Sejal?
Yeah. When we are talking about the pedunculated one, I would like to add one point that you should leave the 1 or 2 centimeter from the myometrial layer, because when when you cut the pedicle, usually that the pedicle contracts. So you may expose the outer serosal layer. So leave certain 1 or 2 centimeter margin for that. And rightly says Sujal bhai, if there are multiple myomas and if they are sitting besides each other or on over the top of each other, then we can use a single incision and take out minimizing the incision is the key for the multiple myomatectomies. So suturing also become little easy and comfortable.
Dr. Gaurav, any takes on this?
I think with respect to fertility, what some people do is also if they reach the endometrium, they also do a hysteroscopy, especially in these fertility cases, and follow them up to see that adhesions aren't formed.
Okay. Anybody about the opening of the cavity, or everybody agrees that you can open up easily?
I think, I mean, this is not a major issue. You just have to close it.
Dr. Tarun, what are your views about opening the cavity?
I think I agree with what everybody had said, really. If we have the cavity, we try not to open it, but if it does open, I'm not going to be too worried. I don't particularly suture it separately. I think there is a school of thought that says to suture it with a 3-0 Weichel, suture the endometrium separately. But that's not something I follow. I would suture, if I open the endometrium, I would suture maybe 2 or 3 layers, suture the myometrium in.
Dr.
Very
Subhash?
rightly pointed, sir. Once the cavity is open, that means we have gone through and through the full thickness of the myometrium. Then the multiple layer sutures are the best to provide the good thickness of the myometrium. Right.
I think the tips and tricks everybody has told about the myomectomy, suturing, and those where defects are more, you can use Interseed for adhesion prevention. Now this question comes for Dr. Yashodan. Yashodan, you are there?
Yes, sir.
How big is big enough to remove through laparoscopy? What are your views?
Sir, I think it's all about how comfortable you are, and especially how comfortable you are with your team. Right now, we've just operated a 20 weeks size of posterior wall fibroid, very degenerated. So I think your limit is only yourself. But of course, at any point of time, if you feel that is too big, I mean, there is nothing to be ashamed of, because for a big myomectomy, couple of things that you have to be extremely careful is, number one, the venous oozing that is going to happen. If you have a trained team, it's okay. But that is one difficulty to control. And second is, if it's an extremely degenerated fibroid, for example, the one that we, in fact, I have not scrubbed out yet also. It's a huge cystic degenerated fibroid, but on our mapping, it was only a pure posterior wall fibroid. So we did have a very difficult time suturing it, but it's just that I'm here at my own setup with my team. There was constant suction and we were just quickly suturing it. So you have to be confident about your suturing. You have to be quick about it if you want to deal with the big myoma. Otherwise, just go for a laparotomy if you're not confident, because there is absolutely no point putting the patient under risk.
What additional consent you are going to take for such patients, Dr. Yashodan?
Sir, if possible, of course, a consent for laparotomy should be taken.
Blood transfusion? Hello, blood transfusion?
Consent for laparotomy should be taken for a big myoma, I feel. Because you never know, because for example, just this patient also, she had posterior endometriosis also. So big fibroids, they often have endometriosis at the POD, and you might get very uncomfortable dealing with it. So don't always be overconfident and say, I'll do 100% laparoscopy. You should always keep a consent for laparotomy, I feel. Should not be ashamed of that.
And you should take an additional consent for a blood transfusion if it is going to require.
Yes.
As your case,
Absolutely.
just now you are telling about the degeneration and taking long time. Dr. Subhash, you want to add something? What is your expertise about the big myomas?
Sir, definitely, sir. We should take all the precautions before you go ahead and as per the size, sir, I think it's your comfort and your expertise that matters at the end of the day. It is nothing like, I do even a 2 centimeter fibroid doing for 2 hours makes no sense. It's the expertise is yours, which matters. Ultimately, it's the patient that matters. And as somebody had put it, I think Dr. Yashodan had put it, there is no harm in doing a laparotomy. I think we have all evolved us and we are all very proud of our credentials as an endoscopic surgeons. But as Damodar also would agree, Sometimes when you have multiple fibroids, we do not have no shame in opening up, having a very small a mini lap incision, taking out the fiber. I think most of us do that for multiple fibers. There's nothing wrong in that.
Very rightly said about Subhash. Now
I'd
you are
also
done.
like to
Yes,
I
please.
also like to add one point is that when you're doing big fibroids, don't hesitate in taking an extra port and an extra assistant, because many a times it makes a huge difference that one extra port, one extra hand in the abdomen will make a big difference. So usually we all are thinking that no, we have to be as minimally invasive as possible, but by adding a port, sometimes it is stitch in time saving 9, something like that kind of a concept, and you'll actually be faster and consequently lesser invasive.
Very rightly said, Dhaval. Now, this patient, which is around 12 week size uterus, they have started a myomectomy, there is a lot of bleeding. What precautions you're going to take to prevent or intervene, or reduce the hemorrhage during the myomectomy? So, Dr. Sujal can take this.
I did mention it last time also. The safest molecule, one of the most commonly used is vasopressin, but you have to be very vigilant in terms of injection. The dilution permitted is not more than 1 in 200 or 1 in 100. So be very sure when you are preparing, because most of the times the assistant is preparing it. So be sure about the dilution. The total volume that you can inject at one point of time should not cross 200. Otherwise, you can very safely use vasopressin. When you are injecting, you should be constantly in touch with the anesthesiologist and also seeing the multipara. In initial injection itself, if you feel that there are changes in the multipara, and then you should stop and switch over to another modality to reduce the blood loss. Plus, there are specially designed needles now very freely available by our own Indian innovator, where you can aspirate it and see that you are in the right plane. Second common method which is being advocated is ligation of the uterine arteries at origin. And it can be temporary, it can be permanent. Especially in infertile patients, you can temporarily occlude these vessels with a suture or with a clip and then remove it at the end of the procedure. And third is hypotensive anesthesia. So you can ask anesthesiologist to reduce the blood pressure, especially when you are opening and closing the myometrial defect, to reduce the blood loss. But these are few methods to control the.
Good. Now I'm going to inventor. Dr. Gaurav, can you just elaborate about the shoelace technique?
Yes, so the shoelace technique is, well, of course, popularized by Dr. Sanket Pisar, where you put a temporary occlusion on the uterine artery. And personally, I don't really use it in practice, but it's a way that you can occlude it, especially in, say, fertility cases like Dr. Sujal Bhai said. And it is fairly convenient if one is used to applying this technique. And there are, of course, two ends, and if you pull one end at the end, the entire vicryl, which is commonly used, can come out.
Yeah, this is really a good technique for those patients with big fibroids, where there are infertile cases, where it is supposed to be preserving the uterine artery blood supply. And that's how Dr. Sanket Pisar, this is Sanket Pisar's video. So I'm thankful to Dr. Sanket. So you can use this technique very well. You have to use it bilaterally. And once you have finished the surgery, then you can remove this knot, which is like a shoelace. So it's called shoelace technique. So
I think alternatively, some people apply a large clip.
Large clips.
Yeah.
Right. Thank you for that. So now we are not going to cover about the suturing, because Dr. Amaya sir has very skillfully demonstrated for 30 minutes about the suturing. Dr. Sejal Naik is going to take this question about the multiple fibroids, how to manage.
So abnormal location of the fibroid, suppose the fibroid is at the cornu or the broad ligament, do you take any special care or special precaution than the routine myomectomy? Dr. Dhaval or the Dr. Shrikant can take this. The location, if it is the fibroid is located at the broad ligament,
For broad ligament or fibroid, you just need to be aware where your ureters are all the time. And exactly like Dr. Nikita Trian said, while removing the fibroid, there are feeder vessels. So you have to be careful about these vessels once you remove the fibroid from the broad ligament, because if you are removing it without like looking at these vessels, then it can bleed profusely inside. So you have to be aware of that, and you always need to have a look at where the ureters are all the time.
So, where would you like to put do you like to dissect the ureter entirely before removing the broad ligament fibroid in all
Not
cases?
not necessarily, ma'am.
And where do you like to put the incision, anteriorly, or would you like to remove it posteriorly?
Uh, that again depends on size of where your how your uterus is moving. So again, if you once you are inside, you decide
Where the
like,
more bulge is there, which
yeah, where the
side
more
the
bulge
more
is there exactly.
nice. Yes.
So any tips about the cervical fibroid, Dr. Dhaval?
So with cervical fibroids, the biggest thing that the biggest challenge is usually the access. So with cervical fibroids, we have to be mentally prepared that in case it's a posterior one, we might have to pull down the rectum, get into the rectovaginal space. If it's an anterior one, be prepared to push down the bladder. So that is there. You have to always have an eye on where the ureters are. So always have a look where the ureters are. Stay within the capsule. Usually, if you're within the capsule, start from the midline and then enucleate. So usually you won't have problems. Give a nice, good liberal incision and just enucleate the fibroid. Once the fibroid is out, repair is relatively easier. The problem is not with the smaller fibroids, but once you have those huge ones, maybe 8 centimeters, 9, 10 centimeters, 15 centimeters, then that becomes really challenging. And because even in these cases, because the supply is all coming from all the parametrial vessels also and everything, so sometimes your uterine artery ligation at source might work, sometimes it might not work. So you have to just be ready with multiple modalities in these cases on how you're going to achieve that avascular space to dissect it. But once again, developing the right plane and enucleating the fibroid is actually the mantra for all fibroids in whatever location it is. If you're in the right plane, take good time getting into the right plane and then just shell it out. So once that is there, so once you're in the right plane, removing it becomes quite easier.
What is expertise of this group about the illumination of the ureters with the striker camera?
So personally, I've just seen it for a demonstration in conferences, but usually you have to have a look before any incision is made, because that time the peritoneum is nice and taut and the ureter is sticking to the posterior leaf of the broad ligament. So at that time, visualization is really easy. But if you open up the broad ligament sometimes and then start hunting for it later on, so then it becomes a little challenging. In those cases, the illumination with the striker system is really good. The only thing is that it only works with the striker camera system. So to use that, then you have to buy a completely new camera system altogether.
Those who have, they can use that system. Firstly, important is to do.
If you have a big hospital like PG Paul, sir, you can buy it.
Okay, so firstly,
also,
important.
I think for cervical fibroid,
Yes,
important thing is always do your transvaginal scan once before
that's
you
what
take
I
up
was
the
coming to. Yeah, fibroid mapping is very important, right?
Yes. And
Yes,
and
you
if
can
you
go ahead.
feel, I actually feel keeping a dilator in the cervical canal sometimes is really helpful. Just in case you go through and through the cervix, you at least don't end up suturing it. So dilator is very important.
Yeah, dilator or even your manipulator will be there in the cervical canal most of the time.
So good fibroid mapping may be required MRI to locate exactly whether it's a central fibroid or lateral wall fibroid, anterior, posterior, so that you can be well prepared with your stenting purpose and if required. So welcome, Dr. Surakshit Batina. What is your take on broad ligament fibroids? How you are going to divide these fibroids like pseudo and true broad ligament fibroid? what is the technique of doing a myomectomy in broad ligament fibroids?
Yes, thank you for the question, sir. For these fibers, usually if you see the ones which are true broad ligament, they always have a very vascular base. So that is something that we need to be quite cautious of. So I always say, be slow and steady over here, because we also have like the large vessels which are going there. So, I always try to use a single myoma spiral, try to do, in fact, it's very easy to dissect in these particular fibroids, but only thing is, at the base, should just not be too quick. You have to go slow and then try to coagulate the base, because it's always having a very thick base with all the vessels. So that's how I usually would tackle the true broad ligament fibroids. Whereas the pseudo broad ligament fibroids are similar like other fibroids. They do have like capsules, so you will be able to enucleate them just like other fibroids.
Like Dr. Tarun, you want to add something about these true broad ligament fibroids and ureteric positioning? Dr. Tarun, you need to unmute, please. Dr. Tarun, you need to unmute, please.
Yeah, sorry, sir. So the true broad ligament fibroids are always, theoretically, they always say that the ureter is going to run is going to be medial to a true broad ligament fibroid. Now, practically, I don't think we always see that, but it is something to keep in mind. So when you are tackling a fibroid, I think like Dhaval had said, we have to identify the ureter before we go ahead with our surgery. You don't have to dissect it out, but you do need to know where it is. So once you've identified it, doing a surgery becomes a lot easier. For pseudo broad ligament fibroids, ureters generally push laterally because the fibroid is arising from the lateral wall of the uterus.
And the traction, counter traction is a very important. It plays a role when you are doing a dissection in broad ligament fibroids. You need to be remaining in the capsule. That is what is very important. Dr. Sujal, any take-home messages for broad ligament and cervical fibroids?
I think all the messages are covered, but these fibroids are little softer than others. So most of the times, once you are in right plane, they come out very well, and the morcellation is comparatively easy with the broad ligament fibroids. But at the end of the procedure, always see the peristalsis of the ureter, so that if accidentally there is some thermal or traction damage, you can come to know immediately. So it is always better, however safety you have taken, to see the complete ureteric pathway before closing. And these are the fibroids. Sometimes if there is hemostasis is not proper, broad ligament can expand and have hematoma. So be sure about the proper hemostasis in broad ligament. Rest all things are already covered. And second is reconstructing the round ligament. Most of the times, we have to cut the round ligament, and it should be properly reconstructed for supporting the uterus.
So many times these are infertile patients. So reconstruction of round ligament is very important part in this. So now coming to the last part of the discussion, Dr. Sejal Naik.
So here for the esteemed panel, what are the common complications for the myomectomy? Are they intraoperatively hemorrhage, or they later on the infection and the abscesses? Conversion to laparotomy, and then the morcellation related side effects. So delayed complications, maybe the secondary hemorrhage, undiagnosed intraoperative injuries, and there is always a risk of recurrence. So what are your experience regarding this port side parasitic myoma, that is the morcellation related long-term complications of the laparoscopic myomectomy after using the power morcellation? So I would like to address this question to Dr. Tarun.
Thank you, madam. Coming to the port side myomas, honestly, I have not faced too many, but I think we have to follow some very basic principles of making sure we are cleaning. I think we've reached a stage where most of us are following either going with in-bag morcellation for our fibroids, or if not, we have to at least make sure that we are cleaning our the abdominal cavity very well. We have to, do a thorough inspection, wash the cavity a couple of times if you are using a power morcellation without a bag. The other possibility of removing fibroids also, I have had fibroids from in the colpotomy. So I use the colpotomy a lot to remove fibroids. I had a patient who came back with a large 10 centimeter fibroid that grew from the vault as well. So just because it came out full doesn't mean there was not seeding of myoma there as well. So you have to be careful about that as well.
So, Dr. Amit, what is your take on the in-bag morcellation versus conventional morcellation?
Ma'am, we have to do the in-bag morcellation, but in rural setup, we don't use routinely. If we counsel the patient regarding the this parasitic, if we don't use the bag, but patient choice not to use the bag because of this costing, and we have taken the consents regarding the same. But at that same time, what we follow that no piece should be remain inside, and take all the pieces outside and buy to the that tubing of the morcellator, and not touching to the any port site incision or any skin. That what we follow here. But definitely we counsel the patient regarding this all post complications.
Any
So,
other
the
any of the panel is not in favor of not using in-bag morcellation?
I think everyone uses bag morcellation, but again, for while doing the myomectomy for the consent, but we are doing in-bag morcellation, but we do take the consent of scattering of cells. There can be scattering of cells, so we take the consent also of that. We mention it in the consent. There can be scattering of cells
So
during myomectomy.
yes, the latest study also showed that even before the morcellation, while enucleation, there is a dispersion of the myometrial cells, which leads to parasitic myoma later on. So one has to still explain the possibility of later complications.
So, Dr. Tarun, you are using in-bag for all cases or only larger fibroids or
Yes, sir.
multiple myomas?
He favors colpotomy, right?
Right.
Yeah, no, if anything smaller, I take it out through colpotomy. Anything under 7-8 centimeters comes out through the colpotomy straight away. I don't, it works very well. It works beautifully to remove most of our fibroids. So you don't require a bag for that. Anything larger than 10 centimeters, then yes, we do use the bag as well. The bag, again, I think like Dr. Amit had said, we do counsel the patients. It's not, I mean, cost factor, I think, is not a problem that we face too much here. Most of our patients are of the more affordable category. So we do counsel them for the bags. We also do scans, which we look at the fibroids, trying to pick up any signs of a possible malignant change. And if there is any sign of a malignant change, then 100% we don't give them the option. We tell them we have to go with the bag. If there are no signs, then we do give them the option of either using a bag or just going without this thing. But I think, like Sir had also said, a thorough washing, get the head up and down a couple of times, wash the entire cavity, a couple of liters of water inside to clean it out completely, will help you find out any small bits that are remaining.
So you are doing MRI for all the patients with fibroid more than 7 centimeter?
No, sir. We do an ultrasound scan first, and based on the findings of that, we decide whether we are going to do an ultrasound. We look at the vascularity, both the internal and the external vascularity. We look at the type of the fibroid, the structure of the tissue, the homogeneity of the tissue. We look at the location, the number, the growth, all those things together. We have a scoring system on which we base it. And if they come in the high risk, then we do an LDH3 and an MRI as well.
Probably Dr. Gaurav or Dr. Dhawan would invent the reusable bag to cut down the cost of this in-bag morcellation, right? So universally in-bag morcellation later on.
I mean, you can make some indigenous bags. I mean, there are all sorts of plastic, IAG gives a lot of brochures. So one of those plastic coverings we can use, but it's not really a question of whether we like it or not. I think once there is a quality assurance committee which says that you have to use it, I think gynecologists will just will have to use it because patients will request.
Dhaval,
I believe that
the cost thing you are used, Dhaval?
I believe, sir, that the cost of the bag is not that much of a deterrent, as is the will of the gynecologist to use it. So we have to be ourselves motivated to use the bag. Once we are motivated,
then we can effort.
Then we can explain it to the patients, counsel them, and most of the times they agree to bear the costs of the bag. So that's what I feel. So we have to convince ourselves first, and once we ourselves are convinced, then we can convince our patients.
Very rightly said, Dhaval. So what is the incidence of recurrence of myomas in your practice? These are certain literature which we got. Dr. Sujal?
So sir, what I generally do believe is regarding recurrences, is that recurrence is usually more of a problem of those small fibroids that we cannot pick up on ultrasound. So those are the ones which pop up back up later on, rather than recurrence of the same lesion. So this is what I usually explain to the patient. So the younger the patient, higher chance of recurrence.
Dr. Nikita was telling about doing ultrasound in the OT. Everybody believes in that?
Yes, so if there are multiple fibroids, then yes, definitely we can.
Dr. Sujal, you can elaborate on this. You are using it right way.
Basically, whenever we are treating multiple fibroids, many a times the deepest and the most crucial fibroid for infertility or AUB are sometimes left out, and they are smaller in size. So at the end of the procedure, when majority of the fibroids are already removed, you can put good amount of 300 to 400 ml of fluid inside and get a very good hydration window, and can see smallest of the fibroids and remove it after mapping. So it is very essential to have a good sonography machine inside the OT, especially when you are dealing with the multiple fibroids. Yes, because you are losing the tactile sensation on laparoscopy, and to overcome that pitfall, you can use this and do justice to the patient. Yes.
Very rightly said, Sujal. Now coming to the last question, Dr. Dhaval, when you use medical management for fibroids, or you never use as a surgeon?
So I think there is no place for the word never in medicine. So there is some of the other conditions where we all use medical therapy. So usually when there are multiple small fibroids, like maybe, the patient has 4 or 5 less than 1 centimeter fibroid, patient is for an embryo transfer later on, and she's asymptomatic, totally asymptomatic. Maybe in those cases, I would like to use medical therapy. There are some patients who are close to menopause and who would want to avoid surgery at all costs. In those patients also, we can give them some form of medical therapy and counsel them that if this works, your symptoms reduce and you go into menopause, so that's how you can avoid a surgery. So I believe, although we surgeons, we believe that we can remove everything left, right, and center, but I think the biggest wisdom comes when we decide when not to operate and how can we prevent a surgery.
And those patients who are waiting for the surgery, like an anemic patient who doesn't want a blood transfusion, these are the patients where it's really beneficial to use.
So, but sometimes when we are going to pre-operative patients, sometimes the planes do get a little messed up with very long-term medical therapy. So that is also then a gray area, that whether to give or not in those patients, and rather we can just give a blood transfusion and build it up and operate at that time.
Dr. Tarun, what is your experience of magnetic resonance imaging guided focus ultrasound?
Not used it, sir. I have read about it, I think, but it's not something that I've ever used. I'm sorry, absolutely no experience on that.
Dr. Gaurav, you want to add something about that?
Well, I know the technique, but personally, I have not used it. Where you use MRI and you use the focus ultrasound on that fibroid. So it's like a interventional technique. But I think the last time I read about it was for my MS exam. But I think if somebody else has a better idea, they can go ahead.
No,
yes.
MRI guided the focus ultrasound is, I think, works better for single fibroids rather than multiple myomas. And given the size of the myoma also does play a role. Because of the degeneration, a lot of the patients, I have seen one patient who had done it, I think maybe in Hong Kong, or I would say Taiwan or Hong Kong, and she had come down. She kept complaining of discharge and pain and a lot of complaints like that. So she was not very happy with the treatment. But it was only, I think, about 3 months after the procedure. I mean, not 3 months, maybe 1 or 2 months after the procedure. So we had just told a conservative management, just wait and see. So I think that is one of the drawbacks of it, but it's not something I would choose. We make our money from surgery.
A few tips about the suturing there, as we have 3 minutes left.
Yeah, so once you have opened the endometrium, so again, if you have opened the endometrium also, it is not a disaster. You can just approximate it, and you just need to don't leave any dead space and don't leave any blood clots inside, so because this can lead to, again, rupture of uterus if she gets pregnant or anything. So just approximate, and then again as Doctor mentioned, the different techniques of suturing. He mentioned it like absolutely well. So, yeah.
So now
One question.
panelists will have one single word about the carry home message about the laparoscopic myomectomy. So doctors, to start with Dr. Amit Tajne. Single message, single word message for lap myomectomy to conclude the session.
Single word, you have to always try to remove it in back.
Dr. Surakshit. Dr. Surakshit, you please unmute, please. Athena, yeah.
Yes, sir. Yes. Sir, I think if one take-home message would be like learn to control the bleeding, and you definitely will rise your confidence while doing myomectomy.
Thank you, Dr. Srikanth.
Yes. Enjoy the laparoscopy.
Dr. Sujal.
Master the suturing technique.
Yeah, very well said. You need to be good in suturing. Dr. Dhaval.
Map the fibroids well, plan your incision. If you do that, half of your surgery is done before even you make the first incision.
Thank you. Dr. Tarun.
Similar, I think similar to what Dhaval had said, it's all about the anatomy. You need to know where your fibroids are, what you're going to cut, where you're going to cut, what structures are around it, and plan your incision according to that.
Yes, Dr. Sejal.
Yeah, fibroid removal, myomectomy is seriously very rewarding surgery. I must say, we could have like both patient and doctor both are happy preserving uterus for future surgery, and for patient also for fertility enhancing and so. So
yes,
one
thank
was
you.
proud of it.
Yes, Sejal, thank you. Look for ureters whenever there is an abnormal positioning of the fibroid like cervical and broad ligament fibroid. I thank all the panelists for such a wonderful discussion. I thank Dr. Komal Chauhan ma'am and wish her all the best for her elections. I'm really thankful to Dr. Sejal Naik for co-moderating the session. And I'm thankful to Dr. PG Paul sir. Over to Dr. Sejal to thank all panelists.
Thank you so much, Komal madam, and all the best for your elections, Dr. Sunita ma'am, for always guiding there, and for all, we are all with you for your elections. Thank you, Kalyan sir. So you made all these efforts and to link everyone. I seriously thank each and every panelist for the crisp answers and very rapidly conclusive panel discussion today. And we are very happy to have our teacher, Dr. Paul sir here. So thank you everyone for joining. Thank you so much, sir.
Thank you, Dr. Sujal. Thank you, Dr. Gaurav. Thank you, Dr. Sejal, Shrikant, Tarun, Amit, Dhaval, Bakshi, Amog, Dr. Surakshit Batina, and Dr. Komal madam for this opportunity. Thank you so much.
Thank you so much, Dr. Kalyan and Dr.
Thank you.
Sejal. I think you have done a fabulous job to sum it up the entire discussion, and we have really received real great response and for the webinar, and the answers and the interaction which was held is so well appreciated, because there are so many take-home messages which everybody has given in their the practical points which everybody has given. Those are something which everybody is looking out, and I thank all the entire panelists, everything, Dr. Sujal, Gaurav, Dhaval, Amit, Tarun, Shrikant, and Dr. Surakshit, and Dr. Deka also, who was there, and Dr. Damodar Rao got to leave for emergency, and Dr. PG Paul, and above all, Kalyan and Sejal, you have really, this was like the grand finale for this laparoscopic myomectomy webinar. And thank you so much for being here. Thank you for your wishes. I really need them. And thank you, Aditi and Amog. I think they have done the
Yeah, thank you. I
Thank
forgot
you,
Dr.
Aditi.
Subhash
Thank
Malla
you,
was there.
Amog.
Thank you, Dr. Subhash and Dr.
Yeah.
Aditi.
Yeah.
Thank you.
Yes. Over to you, Amog.
Yeah. So now we have come to the conclusion of the L alphabet in the series of tasks. Now we move on to the next task in the next webinar. But today it was a complete show, right from the mesmerizing videos of challenges by Dr. Nikita, troubleshooting and managing the fibroids infertility by Dr. Sunita ma'am, and how to suture and how to close the myometrial bed completely properly without causing further complications by Dr. Amay sir. And finally concluding with the panel, which included all your A, B, C's, right up to the Z's of your myomectomy surgeries done laparoscopically. So I would like to thank each and everyone, and I would like to thank Dr. Komal ma'am for giving me this opportunity for being the coordinator for this wonderful webinar. And I would like to hand over the session to Dr. Komal to give the formal vote of thanks.
Thank you so much, Amok. I really enjoyed this episode of L, that is LEAP, laparoscopic myoma. And I thank all the esteemed faculties who have joined, our chief guest, Dr. Prakash Trivedi, guest of honor, Dr. Bhaskar Pal, speakers, Dr. Nikita Trehan, Dr. Sunita Tandulwarkar, Dr. Amay Padmawar, our esteemed chairpersons who joined, Dr. Sandesh Khade, Dr. Sushila Sahani, Dr. Vidya Bhatt, Dr. Ashish Kare, Dr. Jogal, and Dr. I'm not forgetting, but the panelist, and Dr. Damodar Rao, who was there, and the panel, which was so enriching, aptly moderated by Dr. Kalyan, Dr. Sejal. I thank Dr. PG Paul, who has been there from the beginning, but I think he left for the emergency, and all the esteemed panelists who have already thanked now for your valuable inputs and making this panel so interesting. Thank you so much. Thank you, Amok. Thank you, Aditi. I will see you in the next episode, that is episode M, and eagerly waiting to catch up everybody. And at the end, also the Shield Connect team, who have coordinated so well, Sahiti and Nishant and Chitra and team. Thank you so much.